Good afternoon, one and all. Well, we welcome you back after delicious lunch. We are starting our next session. I request Dr. Nemani sir, Dr. Sandeep Nemani sir, uh, our next speaker, uh, to come forward on the stage. Huge round of applause for sir. Thank you, sir. I request Dr. Smita Shete madam, Associate Professor of Pathology, VDGMC, Solapur, and Dr. Mohini Ganu madam, Senior Physician and renowned rheumatologist from Latur, to chair this session. Thank you. Dr. Sandeep Nemani sir is renowned hematologist and hemato-oncologist. Throughout his education, he holds exceptional academic records with gold medal in clinical hematology at MGR University, Tamil Nadu. He established Usha Hematology Center and bone marrow transplant unit at Sri Siddhivinayak Ganapati Cancer Hospital, Miraz. We know his excellent work for leukemias, lymphomas, thalassemia, anemia, aplastic anemia, and so on. He looks forward for comprehensive patient care on reducing hospital visits, making cancer treatments accessible, especially in rural areas. His latest publication on stem cell transplant in acute myeloid leukemia, published in Journal of Global Oncology. I welcome sir to enlighten us on genetic and congenital bleeding disorders. Thank you, sir.
Thank you for the kind introduction, madam. First of all, I thank organizers for inviting me for this mega event. For everybody's knowledge, my half of the genes are from Latur. My mother is from Latur, so it's always happiness to be in Latur whenever I get chance to visit here. So my job has been half done. I think I should say 70% of it is done. PowerPoint mode नहीं जाता. हेच की. PowerPoint readable आहे ना? PowerPoint ला तर केलं पाहिजे ना. Readable नाही PowerPoint. त्याला घेऊ नका. त्याचं काय संबंध? PowerPoint readable नाही. Readable नाही आहे का? Apple कनेक्ट करून बघूया काय? अनु
Sir, this where is your PPT?
फोल्डर मध्ये आहे ना.
कोणत्या फोल्डर? त्याच्यात आहे का? एकदा जस्ट ट्राय करतो.
नाही त्यात नाही. तुमचे कुठे ठेवलेले आहेत पीपीटी? हे काय पीपीटी? पेनड्राईव्ह देऊ का परत?
हो,
पेनड्राईव्ह कनेक्ट करा. ठीक आहे. ऍपल टू दिलं तुमचं
कदाचित
एक्सपोर्ट करत फोल्डर आहे सीएम पीपीटी
बघा.
करून देतो, याची गरज नाही आपल्याला.
ठीक आहे. ह्याच्यातनं घे ना आता पटकन. चालू होते का?
नाही नाही, एकच मिनिट फक्त.
जे आहे ते घे.
हे तुमचे
नाही पण पॉवरपॉईंट मोड मध्ये जात नाही.
पण होत नाही.
तुमचं कोणतं आहे सर यातलं? हे ना?
हे
एक मिनिट करतो. इव्हॅल्युएशन ब्लीडिंग डिसऑर्डर.
जात नाही चटणी घे.
हॉर्मोन मध्ये जात नाही ना. हे करून हे लावून बघ.
हो हो हेच नाही झालं ते हे लावून टाक.
नाही, इथेच जात नाही.
जात नाही.
हे लावून बघ.
पीपीटीचाच प्रॉब्लेम आहे आय थिंक. संगमेशला एकदा फोन करता का ते?
याला लावून घे.
त्याला जाऊन बघ जरा. त्याला किती काय
घेता?
याच्यावरच
त्याला घेऊन तर बघा
ठीक
कनेक्ट
आहे.
होते का तुला. कुठे आहे?
कंट्रोल डी करा.
डिस्प्ले सेटिंग. डिस्प्ले सेटिंग.
कंट्रोल डी मध्ये विंडो डी किंवा कंट्रोल डी करून बघा. विंडो डी. विंडो डी. विंडोचं बटन आहे.
आहे काय ऍपल टू?
नाही
नाही,
नाही
हे
ते तर
C.
झालंय का नाही?
आपण तसं स्टार्ट करू
बघून
नाही
घेतो मी. नाही
तसं
तुम्ही
start.
एकदा 1-2 मिनिटासाठी तुमचं कनेक्ट होतं का बघा. तोपर्यंत इकडे काय
जे आहे.
तर चालू झालं.
झालं.
फक्त तिकडचं बंद करा. ते मला HDMI चं द्या. थँक्यू.
चार्जिंग झालं.
हो लावतो.
रिचार्ज उलट करतोस.
हे निघाले.
उलट करतोस.
ठीक आहे.
So half of my job, or more than 70% of my job, is done by Aruma madam, and so it will be a kind of revision. And we are in the post-lunch session, so I believe that we will do an interactive session. So whatever you have learned in the previous class by Manchanda madam, you have to just revise and just open up and speak what you understood about the evaluation of bleeding patient. So first question is screening test for bleeding disorders. So what is the first foremost thing that you will do when you suspect a patient, whether he's a bleeder or not? Just tell me fast so that we'll not waste too much of time on this. So what is the first thing you want to know? So first thing is history. So history is the very important thing in the bleeding disorder evaluation. Without history, your lab abnormalities have no any value. So it's the most important screening tool in evaluation of bleeding disorders. In absence of symptoms, an abnormal lab value has no significance. So you have to be dig hard to know what exactly the history is and whether the patient is bleeder or not a bleeder. So in history, what are all aspects you will ask? First is the age of onset of bleeding. So if suppose patient is having bleeding disorder at younger age, that means the patient has severe bleeding disorder. Compared to a patient who develop bleeding at later age, that means the patient may have less serious bleeding disorder. Site of bleeding. So the patient who have mucosal bleeds, skin spots, petechiae, purpura, hematuria, epistaxis, these are all mucosal bleeds and the skin bleeds, and we call them as a platelet type bleed or the primary hemostatic defect. Otherwise, the bleed can be deep-seated hematomas, pseudotumors, the joint bleeds, and we call them as the secondary hemostatic defect or the coagulation factor abnormality. This is what the site of bleed will tell you whether it's a primary hemostatic problem or it's a secondary hemostatic problem. The third important thing is the frequency of bleed. As again, the patient who is bleeding frequently in his joint or the skin has a major or serious bleeding disorder compared to patient bleeds infrequently. Is the bleeding spontaneous or traumatic? So again, that will tell you if patient bleeds spontaneously, that means the patient has a serious bleeding disorder compared to a patient who bleeds only after inducing a trauma or surgery. Was any medical intervention required to stop the bleeding? If yes, what? So previously, suppose patient had bled, so somebody might have given whole blood, somebody might have given plasma, and that will tell you whether the patient required any medical intervention and cauterization was done, surgical sutures were taken. So this is also very important. That will suggest you that the patient has a serious bleeding disorder. Then consanguineous parents. So autosomal recessive disorders, as you know, is common in the consanguineous parents, and family history is also important. You know, hemophilia is a X-linked disease, so it runs in families, and maternal uncles can be affected with hemophilias. So this is the significance of history, and history alone will tell you whether the patient is a bleeder and which kind of bleeder the patient could be. Once you know the history, what is the next thing you do? The next you do this basic screening workup for the bleeding disorder. And that includes platelet count, BT, PT, and APTT. And this is the basic screening test that you do to know whether the patient is a bleeder or not. So what is the bleeding time? Bleeding time is nothing but that will look after the platelet and the vessel wall integrity in the hemostasis. Bleeding time in literature has been given by multiple methods. It can be done. Usually what we see in the medical colleges is done by the finger prick method. But what we prefer to do a bleeding time is by the IVs method or the modified IVs method. And in this, the sphygmomanometer cuff is attached and it is inflated to 40 millimeters of mercury. 3 bold stabs from a lancet are taken along the skin lines, and then it is wiped from the sides, not from the top of the wound. And that can give you a bleeding time. As madam had previously told, the bleeding time is absolute as a screening test pre-operatively, but to diagnose serious bleeding disorder, it has definitely a help. So after bleeding time, what next to be done is the prothrombin time and the APTT. So these two tests has been discussed is the cascade, the classical cascade we learned in physiology, where there is two pathways. One is the intrinsic pathway and the extrinsic pathway. The extrinsic pathway starts with the tissue factor, activates factor 7, then 10, and then the common pathway till fibrin production starts. And intrinsic pathway is from surface contact, factor 12, 11, 9, and then factor 10 is activated. So what this test look after is APTT looks after the intrinsic pathway and the common pathway, and prothrombin time looks after the extrinsic pathway and the common pathway. So with this basic knowledge of revision, or we can say recap from the madam's lecture, we will shoot some cases to you and you will tell me what the answers and possible diagnosis could be. So case A, this is 9-year-old male with swollen knee joint, symptomatic since 2 years of age, past history of similar knee swellings on and off, and no significant family history. This is the data you have now. So what we will do is, for every case, we will discuss each and every case with these questions. The first question you have to answer me every time is whether the patient is a bleeder or not a bleeder. Second question you have to answer me whether it's a severe bleeding disorder or mild bleeding disorder. Third, you have to tell me whether it's a primary hemostatic or the platelet kind of bleeding or a secondary hemostatic defect. Third, you have to tell me whether it's an inherited disorder or an acquired disorder. And if at all it is inherited, which kind of inheritance it could be. So this 4 questions you will answer me for every case. So coming to our case. So first question, bleeder, not a bleeder? Tell me fast, bleeder, not a bleeder? Bleeder. Severe, mild? Severe, because joint bleeds are there, no? Then primary hemostatic defect, secondary hemostatic defect? Primary is platelet kind of, joint-seated, joint bleeds. Secondary hemostatic defect. Inherited, acquired, we don't know because there is no family history. So we got a lab evaluation done for this patient. Platelet count was normal, BT was normal, PT was normal, APT was grossly prolonged 151 seconds. So what is the next step when APT is prolonged? Is the mixing study. Madam had discussed in depth about mixing study. So we have to do the mixing study for this APTT. And by mixing study, what you have to do is you have to take a pool normal plasma in equal proportion to the patient plasma, mix it and do the APTT again. If that APTT is getting corrected, that means the patient has factor deficiency. If that APTT is not getting corrected, that means the patient has either a heparin contamination of the sample, it may be fibrin degradation products, or it may be some inhibitors or antibodies against the factors. So mixing study is very important before we proceed further to diagnose what bleeding disorder it could be. So mixing study was done. With normal plasma, it has nearly corrected to 42 seconds. With factor 8 deficient plasma, it has not corrected. And with factor 9 deficient plasma, it has nearly corrected. So that suggests that the plasma of patient with hemophilia was mixed. Hemophilia A was mixed with this patient sample, and that time was not corrected, suggesting that the patient has factor 8 deficiency. So we did the factor 8 assay and that value came less than 1%. So diagnosis is severe hemophilia A. Coming to next case, this is 18-year-old female with intermittent menorrhagia and easy bruisability. History of father had history of gum bleeds and prolonged bleeding after trauma, and grandmother also has easing bruisability. So bleeder, not a bleeder? Bleeder. Severe, mild? Looks mild, no? Some mucosal bleeding and some mild menorrhagia. No medical major intervention, so mild. Primary hemostatic, secondary hemostatic? Primary, secondary, mucosal bleed, menorrhagia, easy bruisability, gum bleeds. Primary. Then inherited, not inherited? Inherited. Kind of inheritance, anybody can tell? Autosomal? Looks dominant, no? In all 3 generations, it is there. The grandmother had, father had, and now this patient had. So this is autosomal dominant inheritance. So we did the workup now. Platelet count normal, bleeding time prolonged, PT normal, APTT prolonged. So we have two abnormal parameters now, BT prolonged and APTT prolonged. So we went ahead and did the mixing study for the APTT. Again, that was not corrected with the factor VIII deficient plasma, suggesting that the factor VIII may be low. We did factor assay, came as 27%. So it's mild hemophilia, right? But BT is also prolonged. Why in hemophilia the BT should be prolonged, right? And the patient is female. Usually females are not sufferers in hemophilia. Males are the sufferers and the females are the carriers. So what it is? Mild hemophilia A or female hemophilia? What it is? So what next has to be done? Because BT is prolonged, we did a von Willebrand factor antigen and that came low. So suggest that it is type 1 von Willebrand. This is very common disease to cause mild menorrhagia in female. You have to see the BT as well as the APTT, and if it is prolonged, you have to do a von Willebrand antigen level to know whether it's a von Willebrand disease. It's an autosomal dominant disease, type 1. Type 3 is very severe disease, which is behaving like hemophilia. It is autosomal recessive. And for type 2, there are multiple other varieties of von Willebrand diseases where some are autosomal dominant, some are recessive, and the variants are picked up on some higher investigations. But routinely, type 1 is very common disease in the community. Coming to next case, this is 11-year-old boy referred by ENT with complaints of epistaxis. He had two episodes, one requiring external pressure for 5 minutes and other stopped on its own. No other significant history of prolonged bleeding. Bleeder, not a bleeder? So confused, right? Whether to call it as bleeder or not, because mild epistaxis, local pressure, it has stopped. It can happen in children, no? So for this, we don't know whether it's a bleeder or not on history. So there should be some objective parameters to know whether the bleeding tendency is there or it's normal. So for that, there are a lot of questionnaire or the assessment tools are there. We call it as BAT score, bleeding assessment tools. And the most commonly and widely used is the ISTH, International Society for Thrombosis and Hemostasis, BAT score. And where for every bleeding parameter, there are scores given. So you can see for epistaxis, there are 4 scores, cutaneous bleeding, oral bleeding, GI bleeding. And for every, you have to just score them and you have to calculate the total score of the patient. If suppose for an adult male, the score comes more than 3, the patient has significant bleeding. For adult female, score more than 5, significant bleeding. And for child, more than 2 score, it's significant bleeding. So by this, you can decide whether the patient is a bleeder or not a bleeder by just doing the questionnaire of the bleeding by ISHTH BAT score that is easily available on the net. And now this child more than 5 or more, like it has stopped within 10 minutes and its score is only 1 for the epistaxis. So score 1. Bleeder, not bleeder? Not a bleeder, but still patient was referred to us. We did the bleeding evaluation done. Platelet count normal, BT normal, PT, APTT normal, von Willebrand antigen normal. Diagnosis, no intrinsic hemostatic defect in this child. Coming to next case, 22-year-old female was being evaluated for menorrhagia. Her periods lasted for 8 to 12 days since menarche, requiring treatment with antifibrinolytics and hormonal therapy. Patient also had several nosebleeds which needed cautery. She also reported to have 2 sisters also having long menstrual periods, and her brother needed transfusion following an appendectomy. On examination, the patient was pale because of blood loss and had large bruises in the extremity. So this is the profile you have. Now we'll put this patient in the BAT score. And for epistaxis, we got 3 score. I'm just going a little fast. Cutaneous extensive, again score of 3. Then for menorrhagia, she required fibrinolytics and hormonal therapy, score 3. So bleeding score 9. So she's a bleeder, right? So patient is a bleeder. Second question, severe, mild? Severe bleeding because a lot of things is happening. Cauterization has been done. Primary hemostatic, secondary hemostatic? Primary hemostatic because all are mucosal and the skin bleeds. Inherited, acquired? Inherited, no? Siblings are affected. But only siblings are affected. So kind of inheritance? Probably autosomal recessive. So lab tests were done. Platelet count was normal. BT was prolonged. PT, APTT normal. So you have an isolated BT abnormality. What you're suspecting now? Platelet dysfunction because the platelet count is normal. So von Willebrand antigen was also done for completion. That was normal. Clot retraction test, absent clot retraction, again suggestive of poor platelet function. Light transmission aggregometry was done, absent response to all agonists except ristocetin. Flow cytometry analysis was done, suggestive of absence of or reduced GP2B3A expression, suggesting of diagnosis of Glanzmann's thrombocythemia, which is a congenital disorder of autosomal recessive variant where the patient has no platelet aggregation. And I'll just brief you about this. What is this light transmission aggregometry? This is there available at few centers in the country where when the platelet-rich plasma is suspended through a light, the light is not transmitted because the platelet is suspended whole over in the solution. But when you put some agonist which causes platelet aggregation, the plasma gets cleared and light starts transmitting. So from zero light transmission in a platelet-rich plasma, it goes up to 100% once the agonist which is causing platelet aggregation is put in. So this is how it is. These graphs are plotted. After putting agonist, immediately the platelet starts clumping and the plasma gets cleared and lights gets transmitting to the solution. And depending on the type of curves you get, you diagnose different conditions like Bernard-Solier, Glanzmann's storage pool. Nowadays, we have easy access to doing NGS testing, clinical exome sequencing testing done, and we can diagnose this genetic disorder by sequencing as well. But these are the functional tests that will tell you in vitro function of the platelet, how they are behaving. And this is the patient's curve. Response to ristocetin was there, but no response to addition of ADP, adrenaline, and collagen, suggesting that the patient is suffering from Glanzmann's thrombocythemia. Coming to next case, 16-year-old female, menorrhagia since 8 months, presently taking levonorgestrel for that. Recurrent episodes of gum bleeds and epistaxis present since 9 months of age, for which blood and FFP were transfused. Occasional history of hematuria, joint bleed, and melena. So we'll put in the score fast. Epistaxis score 4, oral cavity score 4, GI bleed score 1, menorrhagia score 3, total score 13, bleeder not a bleeder, bleeder. Then second question, severe mild, severe, joint bleed is also there, remember that point. Primary hemostatic, secondary hemostatic, secondary because few episodes of joint bleeds are also there. So inheritance pattern, we don't know because there is no family history. We got a workup done. Isolated PT was prolonged. Platelet count BT, APTT normal, suggesting that where is the problem now? When the PT is isolatedly prolonged, it's in the extrinsic pathway. Suppose PT, APTT both are prolonged together, then it becomes a common pathway defect. But if it is isolated APTT, then intrinsic pathway abnormality. When PT alone is abnormal, that means there is extrinsic pathway abnormality. And in extrinsic pathway, only one factor comes. Which is that factor? FAS7. So we got a factor 7 assay done, and the patient's factor 7 assay was less than 1%, suggesting a severe factor 7 deficiency in this patient. Coming to next case, 55-year-old female posted for hysterectomy, referred in view of prolonged APTT. Now, a lot of surgeons will hear about APTT in all the lectures, and then tomorrow onwards, they will start doing APTT as well with BT, CT, PT. So APTT came prolonged, so patient was referred to us for fitness for surgery. Past 2 normal deliveries, which was uneventful. This is very much important history because previous hemostatic challenges were normal. That itself suggests that the patient may not have any significant bleeding disorder, which is of congenital origin. So previous 2 normal deliveries, which were uneventful. Pre-op bleeding screen was done, which suggests platelet count normal, BT normal, PT normal, APTT was grossly prolonged. So now we have to find a solution why the APTT is grossly prolonged. What is the next step? Mixing study, right? So mixing study was done. It has corrected with normal plasma. Suggestive of what? Inhibitors or factor deficiencies? Factor deficiencies. So we got a factor assess done. Factor 8 was normal. Factor 9 was normal. Factor 11 was normal. What remains is factor 12, which came less than 1%. What we did, we labeled the patient as factor 12 deficiency, but we cleared the patient for surgery. Factor 12 is not required for hemostasis. If you were alert in the madam's lecture, madam told this, that factor 12 is not required for hemostasis because the intrinsic pathway starts from factor 12, but still it is not required in hemostasis. So I have 3 questions in my mind. Madam has already discussed this, but you have to answer me this. If factor 12 is essential for hemostasis, then why do people with factor 12 deficiency don't bleed? Because it's there, it's here. The intrinsic pathway starts with factor 12. The second question is, if factor 11 is the only way to activate factor 9, then why do only 50% of patients with factor 11 deficiency bleed? And the third question is, if the intrinsic and extrinsic pathway can activate the thrombin independently, then why do patients with factor 8 and factor 9 bleed? Because if suppose patient has hemophilia A or B, extrinsic pathway is still active to produce the thrombin, then why do they bleed? So these are the 3 questions that this classical cascades don't explain us. And this is what the madam told in the morning, that they are the in vitro, the tests which we are doing, the PT and APTT, they follow these principles. In vivo, this is not followed. So what is followed in vivo is this. So the first in coagulation system, the first phase is the initiation phase, where factor 7 is activated to factor 7A. And that factor 7, that is the extrinsic pathway I'm talking about, activates factor 10 and a small amount of thrombin is produced. This factor 7 produces only small amount of thrombin. And this thrombin in turn stimulates the propagation phase, where that stimulates the factor 11, 8, 5 independently of the factor 12 and 11 and causing burst or large amount of thrombin is produced, and which leads to stabilization phase and the fibrin production and the clot stabilization. So this is what happens in vivo. So there is no factor 12 required for thrombosis. Even factor 11 is also not much required. And rest factor 8, 9 are very important for the propagation phase of the hemostasis. And this is very important to know that the test behave like intrinsic, extrinsic and common pathway. But actually in body, this is happening in this way. And where you know where this is happening? Is it happening in the plasma? Where it is happening in the blood? It's all happening on the surface of the platelet. So once the platelet gets activated, it throws a lot of pseudopores and the surface area of platelet increases. And on that surface of the activated platelet, the coagulation cascade happens. So platelet does the brickwork of the thrombosis and the cementing work is done by the coagulation system on the platelet surface. You imagine where it is happening now. So next case G, 65-year-old male with chronic renal failure. This madam has already been discussed in the morning. Sudden onset of ileopsoas hematoma at 65 years of age with ecchymotic patches all over. No previous history of bleeding, no family history of bleeding. Now tell me, bleeder, not a bleeder? Fast. Bleeder, no. Ileosomas hematoma is a big bleed. Severe, mild. Severe, mild. Severe. Deep-seated ileosomas bleed is a severe bleeding. Then primary hemostatic, secondary hemostatic. Secondary because deep-seated hematomas, right? Acquired or inherited? Acquired because now no past history at age of 65. We don't expect severe bleeding disorder to happen suddenly at 65 years of age. So it's an acquired condition. We got a basic workup done. Platelet count normal, BT normal, PT normal, APTT grossly prolonged. Next step, mixing study. Mixing with normal plasma, not fully correcting. Factor 8 deficient plasma, not correcting. Factor 9, partially correcting. We got a factor 8 assay done. That was less than 1%. Because it was not fully correcting, we did a inhibitor screen and that came positive. And inhibitor assay by Bethesda method was done. It was 34. The patient is diagnosed with acquired hemophilia A. And that can happen because of antibody developed against the factor 8. We have around 5 to 6 patients of hemophilia A which are acquired. And the treatment is not the factor supplementation. Treatment is immunosuppression. Like we treat ITP, autoimmune hemolytic anemias, like that we have to give immunosuppression. And we have to find out some primary cause. Some patients may have some autoimmune diseases. Some patient may have some malignancy. So we have to do extensive workup to rule out primary cause of acquired hemophilia A. So it's a rare autoimmune condition. Patient have negative past history and family history of bleeding, predominantly a disease of elderly, occurs due to production of antibodies against the clotting factors. Coming to next case, 7-year-old male child, second degree consanguineous parents, maternal cousin had bleeding disorder and had spontaneous cheek hematoma. Patient had umbilical stump bleeding that we asked multiply, then they told, yes, patient had delayed umbilical stump bleeding and requiring FFP transfusion at birth. This is very important clue if anybody can pick. So I'm highlighting that point. So bleeder, not a bleeder. Severe, mild. Severe, no? Big cheek hematoma was there, umbilical stump bleeding, severe. Primary hemostatic, secondary hemostatic. Primary, I told you, no, epistaxis, secondary hemostatic defect. Acquired, inherited? Inherited, because there is a family history. Inherited. Mode of inheritance? Maternal cousin was affected with consanguineous parents. So hopefully autosomal recessive. So we did the workup done. PT, APTT, BT was normal. Everything came normal. The screening workup is normal, but still the patient is a bleeder. So what next to do? We have to do a urea clot lysis for looking at the factor 13, and that was abnormal. The child was labeled as congenital factor 13 deficiency. Coming to next case, 8-year-old girl child, intermittent episodes of gum bleed and epistaxis requiring medical intervention on 2 occasions. Bleeder, yes, of course, because medical interventions are required. Severe, mild? Mild. Then primary, secondary? Primary. Okay, then lab evaluation was done. Isolated BT abnormal, PT, APTT and platelet count normal. What next? Now a BT which is abnormal. So platelet dysfunction you are suspecting, right? Again. So von Willebrand factor was done. That was normal. Platelet aggregometry was done. Absent response to all except ristocidin. Flow cytometry showed normal expression. So no decreased expression of either the Burnout cellular or the Glanzmann's like syndrome. So we did a PS. As madam emphasized, the first test to begin with in any coagulation parameter testing is the CBC, and the PS showed eosinophilia. Patient had acquired platelet dysfunction due to eosinophilia, and they behave like storage pool disorders. And once you correct the eosinophilia by giving deworming or hetrazine, the eosinophilia settles, the bleeding problem also settles. So acquired platelet dysfunction with eosinophilia is a syndrome characterized by reversible spontaneous hemorrhagic diastasis. Platelets are usually bizarre, varyingly sized, pale stain, and poor granulation because it is behaving like storage pool disorder. And it is also called as allergic vascular purpura or non-thrombocytopenic purpura with eosinophilia. And this is the brief mechanism how the parasitic infection causes antibody antigen mediated complexes, and that causes platelet degranulation, and they make the platelet dysfunctional, causing storage pool deficiency, which is acquired. So understood. The coagulation, I try to simplify the cases very much, but you know, coagulation is like a female mind. Seems to be very simple, but understood by none. So though it's very simple, still we have to break head when we evaluate and we try to diagnose the patients with bleeding disorder. So just this slide you have to take with you. This is very important. Low platelet count, BT prolonged, PT-APT normal diagnosis. Tell me fast. Thrombocytopenia. So BT is prolonged. Never do a BT in patients with thrombocytopenia. No point doing that. Normal platelet, just one last slide, madam. Normal platelet count, BT prolonged, PT-APT normal. Diagnosis, platelet dysfunction. Normal platelet, BT prolonged and APTT prolonged. Von Willebrand disease. Isolated APTT prolonged. Intrinsic pathway. Isolated PT prolonged. Both PT-APTT prolonged. Common pathway. You have to do fibrinogen factor 10. Then everything normal, still a bleeder. Or one discussed just now, factor 13 deficiency or any other abnormality. So this algorithm you should know when you screen the patient. This is what the conclusion you should come in your mind, and then do the workup beyond this. I acknowledge Dr. Sukesh Nair. Whenever I start presenting about coagulation anywhere, I first think about him. He's my mentor. Whatever little knowledge of coagulation I have, this is all because of him. Whatever I learned from him, you might know this great personality. And of course, my wife who compiled these cases for me, given me this presentation prepared to be presented in front of you. Thank you. Thank you very much.
Hello.
Thank you, sir, for so nice interactive session. It's made very easy with the innovative questionnaire form. Thank you so much. I request chairperson to felicitate sir.
Can I ask one question? Yeah. Very nice lecture, doctor. Very informative. What is the role of genetic therapy in these disorders?
What is the role of?
current genetic therapy? Gene therapy.
Yeah, so gene therapy, madam, is coming in big way for hemophilias. Like for hemophilia A, already as in the morning, Melankari sir had discussed, Dr. Alok Srivastava already started in India the gene therapy for hemophilia A. So slowly for hemophilia it has started. For other, like hemophilia is the commonest, A is the commonest bleeding disorder. So first that will happen for hemophilia A, then it can go to hemophilia B, and then slowly it can come to other bleeding disorders. But otherwise, as of now, supportive care and the factor support, other than that, we don't have too much any options for treatment.
Thank you very much. Any question from audience?
Thank you, sir. And at tertiary healthcare like Solapur, we can do simple tests like mixing study.
Correct.
And we can come to near or approach to the diagnosis.
Yes.
Where there are limited resources.
So mixing study, whenever you have an APTT prolonged in your lab, you have to always give report with mixing study, because isolated APTT prolonged report alone has no value unless you do mixing study. And then you have to conclude whether it's a factor deficiency or in some inhibitor. Sometimes the patient's sample are taken from the central lines. So heparin contamination can be there with the sample, and APTT can come prolonged. So where you have to tell by mixing study that it's not correcting. So it's not factor deficiency. Sometimes the patient may have antiphospholipid antibody syndrome where APTT can come prolonged. In that case, also you have to do mixing study and tell that it's not correcting. So you have to look for lupus anticoagulant and the workup for inhibitors, not the coagulation disorders. Yeah.
Any questions? Thank you. May I request chairpersons to felicitate sir? I request Dr. Madam Ganu Madam and Kiste Madam, please be on stage for the felicitation. I request Dr. Shivaji Birare sir, Professor and HOD, GMC Sindhudurg, to felicitate our chairpersons. Thank you so much, ma'am. Thanks, Ganu ma'am.
Thank you. Now, let's proceed with the updates on myelodysplasia by Dr. Anushri Prabhakaran, a renowned expert in the field of hematology. I request Dr. Jayashree Khiste ma'am, Associate Professor, VMGMC Solapur, and Dr. Anita Mahanta, ex-HOD, Professor, Department of Pathology, MRMC Kalburgi, to chair and moderate this session.
She is a renowned clinical hematologist and a general physician. Ma'am has been practicing since 70 years in this field. She is a member of European Society for Aesthetics.
That's it.
How do you make it full screen? Slides. Current slide. Good afternoon. Let me start by thanking IMA for having me here today. So let us start with the story of the 68-year-old gentleman with diabetes and hypertension who presented in March 2024 with axillary lymph nodes and anemia. He was referred from General Medicine Department for the evaluation of lymphadenopathy and anemia. This was his hemogram. So he had a hemoglobin of 8.7 gram, WBC count of 6,400 with a platelet of 59,000. And neutrophil count was low at 27% and lymphocyte was at 57%. And there was 5% atypical cells. So as a clinician, I felt that will be dealing with what kind of disorder? Does anybody want to comment? Lymphadenopathy and some pancytopenia. Obviously, I was expecting I will be dealing with a lymphoproliferative disorder. So asked for bone marrow aspiration biopsy, lymph node biopsy, and for staging whole body FDG PET CT. So the bone marrow report came with a surprise. So there was the presence of 15% blasts. It was a hypercellular marrow with diffuse increase in mononuclear cells, both blasts and lymphoid cells. The CD34 stain confirmed the presence of increase in blasts, which was counted up to 15. And CD20 immunostain confirmed the presence of increase in B lymphoid cells. So there were two disorders in the marrow, which was not suspected from the clinical presentation. So the flow cytometry confirmed that the B lymphoid population was a clone of chronic lymphocytic leukemia, and the blasts were myeloid blasts, which were 14.3%. So this was the final flow report. The PET CT revealed presence of extensive lymphadenopathy, making it stage 4 disease. And the lymph node biopsy confirmed that it is small lymphocytic lymphoma, which is the counterpart of CLL. He underwent further genetic workup. The myeloid NGS panel, which we routinely do in a suspected case of myelodysplastic neoplasm and AML, it confirmed the presence of TP53 mutation with a VAF of 26.83%. So VAF more than 10% confirms that it is monoallelic TP53 alteration.
and his CLL fish panel revealed the presence of 17p deletion. So this confirms that in one of the chromosomes, the 17p is deleted, and in the other one, it is mutated. So it makes it as a biallelic TP53 alteration. So the final diagnosis was made as myelodysplastic neoplasm with increased blast 2 with chronic lymphocytic leukemia. We cannot comment on the stage of it because we don't know the cytopenia, whichever, what is the predominant component of it with biallelic TP53 alteration. So it is extremely important to do a bone marrow examination. Many times when there is peripheral blood is showing lymphocyte predominance, sometimes we go for peripheral blood flow. We would have missed the underlying MDS in such a scenario. So the two diseases can coexist. It is important to carry out relevant genetic tests. Otherwise, we would not have been able to know the biallelic TP53 alteration in this case, which will give him an extremely poor prognosis. And one has to decide which disease to be treated. So this patient was treated. We considered that the CLL is an indolent condition and let us wait. And MDS IB2 has a significant risk of progression in the next 6 to 9 months to an acute myeloid leukemia. So he was treated with this combination of low intensive therapy with azacitidine and venetoclax. At the moment, he is receiving cycle 7 now with a hemoglobin of 9 gram, WBC count normal and platelet count 1.3 lakh with normal differential count. The recent bone marrow examination done still shows the presence of 8% myeloblasts and persistent CLL clone. So with that background, let me go to my topic proper, which is updates in MDS. So we'll go to the introduction. This will be the roadmap. What is new in classification, what is new in prognostication, what is new in treatment, and finally summary and conclusions. This is a kind of difficult topic. If you find that it is overhead projection, you can stop me at any point of time. So myelodysplastic neoplasm is a bone marrow failure syndrome, usually presenting at a median age of 70 years, phenotypically manifesting as cytopenia in one or the other lineages like anemia, leukopenia, or thrombocytopenia, and the bone marrow showing morphologically dysbiosis in one or the other lineages. This condition has a myriad of cytogenetic abnormalities. So one is supposed to do fluorescent in situ hybridization and karyotype to assess the chromosomes and myeloid NGS panel to see what are the various mutations present in that particular patient, which has got prognostic value. And around 30% of these individuals have a potential to transform to acute myeloid leukemia. One has to know that although it is usually seen in elderly population, it is still not limited to elderly. This is a story of a 19-year-old girl who presented with transfusion-dependent anemia in late 2022 without any evidence of hemolysis, PNH. The bone marrow was hypercellular with no evidence of dysbiosis. Myeloid NGS panel was normal, karyotype was normal, FISH was normal, microarray was normal. And autoimmune workup was normal because there is anemia, but hypercellular marrow. Autoimmune workup also was done, which was normal. She was given a therapeutic trial of steroids. There was no response. Her erythropoietin level was low for the degree of anemia. So a trial of darbepoetin alpha was given, still did not show any response. Finally, with a possible diagnosis of myelodysplastic syndrome RA, in the previous classification, lenalidomide was initiated, and for the last 2 years, she has been remaining stable with a hemoglobin of 11.4 gram and other counts relatively normal. This is the story of an aspiring dentist, a young boy who presented in May 2024 with anemia, leukocytosis, and thrombocytopenia with history of recurrent infections. Because he decided not to go for any particular treatment, on initial evaluation, he was found to have myelodysplastic syndrome with a blast count of 7% in the marrow. There was dyserythropoiesis, dysmyelopoiesis, and dysmegakaryopoiesis noted in the marrow. After 5 months, he progressed frankly to acute myeloid leukemia. His cytogenetics and mutations did not suggest such an aggressive disorder. So all of them were normal. So he's right now undergoing the first session of azacitidine plus venetoclax, and the plan is to go for allogenic stem cell transplant. So one has to remember that it may not be accompanied by typical bone marrow picture. Second, cytogenetics, autoimmune workup, and myeloid NGS panel could also be non-contributory in many cases. We may have to go by clinical picture and therapeutic trial of different agents. So this makes MDS as a most diverse syndrome and a most difficult syndrome for clinicians to manage. So let us go to the basics. So when there is a normal hematopoiesis, normal stem cells are there, and it different proliferates and differentiates into various cell lineages. When there is a clonal hematopoiesis, there is a hit to the genome, and it gives a survival advantage to the mutated cell population, and it slowly proliferates. With a perfect storm of mutations and various cytogenetic abnormalities, and with appropriate epigenetic factors and microenvironment, it slowly progresses to myeloid malignancy, myelodysplastic syndrome, and AML. So these mutations can be acquired starting from embryogenesis. So some of them, many of them are inconsequential, and some of them can give the survival advantage and growth potential. Those are called as clonal hematopoiesis. In elderly population, it may be up to 20% of elderly population can show presence of clonal hematopoiesis, and slowly they can progress to MDS or AML. And some of them can have cardiovascular disorders like increased predisposition for stroke and autoimmune disorders and myocardial infarction. So these are the common chip mutations identified, like DNMT3A, TET2, A6L1. These they look like permutations and combinations of various alphabets, but they have relevance. We practicing clinicians are also comfortable with only few of them. Many times we have to go back to the internet to know exact relevance of many of them. So CHIP is presence of mutated stem cells, which gives selective growth advantage with a variable allele frequency of more than or equal to 2%. What does it mean? VAF means, suppose you look for the particular mutation in a particular gene. So 100 DNA molecules are tested. Out of them, 2 or more are showing the mutated variant. That means VAF is more than 2%. And they will not have cytopenia, they will not have frank myeloid malignancy. And the risk of progression to AML or MDS is 0.5 to 1% per year. So with that background, that is how the MDS evolves, starting from CHIP to clonal cytopenia of undetermined significance to myelodysplastic neoplasm. So patient should present with a cytopenia in one or the other lineages with hemoglobin of less than 12 gram for female, 13 for male, absolute neutrophil count less than 1,800, and a platelet count less than 1.5 lakh. One has to exclude other causes of cytopenia. It could be drugs, it could be autoimmune disorder, it could be alcohol, it could be aplastic anemia. It could be viral infections like HIV, and very common condition, vitamin B12 and folic acid deficiency. Once these two are prerequisites, these should be there along with morphological criteria. When we look at morphology, what I as a clinician look at is, when I see the bone marrow report, I look what is reported. It is a hypercellular marrow or a hypocellular marrow. Second to look at is, what is the blast count? If the blast count is between 5 to 19%, I don't have to look anything further. So whether there is dyserythropoiesis, whether there is ring sideroblasts, 5 to 19% blasts in the marrow confirms the diagnosis of a myelodysplastic syndrome with increased blasts. Next, if that is not there, then I have to read the detailed description of various cell lineages to look at how much is the percentage of dyspoiesis in different lineages. It has to be more than 10% in at least one lineage to categorize as dyspoiesis of significance. Next, look at the iron stain and see whether ring sideroblasts have been reported or not. Finally, look at the reticulin stain and see how much fibrosis have been reported. So the major criteria is presence of dysplasia in more than 10% cells in one or more lineages, presence of ring sideroblasts more than 15%, or if there is a presence of a specific mutation called SF3B1, 5% is more than 5% is enough, presence of myeloblast 5 to 19%, and all these patients, from that, if the suspected diagnosis is myelodysplastic neoplasm, one should undergo a karyotype, because you cannot do a karyotype on an old sample. So if the bone marrow aspirate is suspicious, one has to ask for a karyotype the day one itself. So there are some typical karyotypic abnormalities seen like 5q deletion, deletion 7, and complex karyotype, which are specific for myelodysplastic syndrome. So at least one major criteria along with both the minor criteria are both the prerequisite criteria are required to make a diagnosis of myelodysplastic neoplasm. Then comes what is new in classification. 2022, the WHO 5th edition has come up with a very simplified classification for myelodysplastic neoplasm. So ask for history of chemotherapy and radiation. If that is there, and there is pancytopenia and dysmyelopoiesis or erythropoiesis, one can label it as myelodysplastic neoplasm post-cytotoxic therapy. Next is look at 3 genetic abnormalities. One is 5q deletion, second is TP53 mutation, biallelic, and third is SF3B mutation. And next is morphological classification. It's also been very much simplified. Presence of low blast, increased blast, and hypoplastic MDS. One which is not included here is MDS with fibrosis. So this has been the previous classification, WHO 2016 and WHO 2022. I think let us not go into the detail of it. So just so that you differentiate it. So in 2016, it used to be called like the MDS with single lineage dysplasia, with multilineage dysplasia, those with ringed sideroblasts, which has got single lineage dysplasia, multilineage dysplasia like that. Now it has all been simplified into low blast and increased blast, and with TP53 mutation and with hypocellular MDS and MDS with fibrosis. Many people follow ICC 2022. I think let us not go into that. It makes it a little more complicated. The changes have been, the term syndrome has been changed to myelodysplastic neoplasm. MDS unclassified terminology has been removed. Excess blast is changed to increased blast. Hypoplastic MDS and fibrotic MDS terms have been added, and this is a must to do SF3B1 mutation and TP53 mutation. Although the terminology has been changed to myelodysplastic neoplasm, the acronym remains MDS. Next come, what is the change in prognostication? This used to be the traditional prognostication with international prognostic scoring system. Nowadays, most of us follow IPSS-R, revised IPSS. Let's not go into the detail of the same. Now we know that various mutations are very important for prognostication of myelodysplastic syndrome. These are many of them which have been described. More than 90% of the patients with myelodysplastic neoplasm have one or the other mutation. Average number of mutation per patient is 4 to 5. And as the number of mutations increase, the prognosis worsens. And some of the mutations can really skew the outcome, like TP53 giving a very bad outcome and SF3B1 patients remaining quite stable. So the recommended prognostic model right now is IPSS-M, M standing for molecular, which includes the clinical characteristics like blast count, hemoglobin count, platelet count, along with IPSS-R cytogenetic category. And there are 16 genes here and 15 genes here, total 31 of them. And according to IPSS-M, if somebody is categorized as low risk MDS, their median survival is 6.3 years, whereas the high risk one has a median survival of 1.5 years. So this is not a difficult tool to be used. So if you have internet in your clinic, you just type this out, mdsriskmodel.com. This is available free. Once you open this, this is what comes up. So one has to enter the clinical data, patient detail, age and all, the blast count, the hemoglobin count, platelet count. Then you enter the cytogenetic data, whatever karyotype has shown or whatever the fish panel has shown, and the molecular data. So if you don't have some of the data available, you can just put NA, what you see here. So then it will give what is the IPSS-M category and what is the expected outcome in years. So it becomes very easy for the clinician to describe to the patient what is their expected course. Why do we have to differentiate between low risk and high risk MDS? Low risk MDS is differentiation arrest leading to cytopenia, where clinician is interested in managing the anemia part of it. And in high risk MDS, it is expansion of clonal cells with a potential for fast progression for AML, where one wants to do the disease modifying therapy. A touch upon SF3B1 mutation, update on MDS, one should at least remember this part. SF3B1 mutation is a spliceosome mutation. It gives an indolent course to the disease, and presence of ring sideroblast. If somebody has a myelodysplastic neoplasm with a ring sideroblast, it's a very high chance, more than 75% chance that the patient has SF3B1 mutation. And what is it with this TP53 mutation? We know that TP53 stands for tumor protein 53. It's a tumor suppressor gene. So if somebody has a TP53 mutation to begin with, it's called, if it's congenital, it's called Lee-Fermani syndrome, very high risk for developing various malignancy. And if it is after a therapy or something, it's only monoallele hit. And patient requires another hit to develop, a second hit to develop frank myeloid neoplasm. If someone has a TP53 mutation biallelic, then you can see the survival is extremely low compared to those without the mutant. And the third part of it, what is new in treatment? So what we discussed till now was what is new in classification, what is new in prognostication. The classification was 2022 WHO 5th edition classification, and the prognostication was IPSS-M. These are the two things which one has to remember. And what is new in treatment? In low risk myelodysplastic neoplasm, 3 drugs. Lenalidomide in 5q deleted patients, luspatercept as a first-line therapy for managing anemia, especially in SF3B1 mutation, and imetelstat. This received FDA approval as a second-line therapy for managing anemia in patients who have failed erythropoietin. So low-dose lenalidomide, Sintra-Rev trial. So even if the patient is 5q deleted, but patient is having mild anemia, not transfusion requiring, even in them, if you start low-dose lenalidomide at 5 milligram per day continuously, then there is delayed or decreased transfusion dependency. There is increased cytogenetic response, and the drug has an acceptable safety profile, and it gives response even in TP53 mutated patients. Second drug, luspatercept. It's an erythroid differentiating agent. Let's go, not go into the mechanism of it. So after this medalist trial where it was compared with a placebo and the COMMANDS trial where it was compared with erythropoietin, it has shown efficacy in improving the hemoglobin level and reducing the transfusion requirement in MDS patient, especially those with SF3B1 mutation. This can be used as a first-line therapy in patients having SF3B1 mutation who has a transfusion-dependent anemia. Third drug is imetelstat. It is a telomerase inhibitor. It's very interesting to note its mechanism of action. So this is telomere is the end part of chromosome. It is required for as one ages, as a cell ages, the telomere length comes down. It is the telomerase enzyme which keeps up the length of the telomere. Some of the malignant cells have the potency, capability to, they have upregulated telomerase activity. So their telomere doesn't shorten. So they don't undergo apoptosis. So this is a telomerase inhibitor. So the telomere length shortens ultimately, and the cell undergoes apoptosis. So this has received FDA approval for use in MDS patients who have failed erythropoietin, who have anemia. Then the dose of darbepoetin. Darbepoetin, although it's not an FDA approved agent, this is routinely what we follow as the first line therapy for managing anemia in MDS patients. So what we end up using is 500 microgram once in 3 weeks, but one of the papers shows that if you use 300 microgram weekly, it gives a 71% response rate in anemia. What about high-risk MDS? Nothing big has happened in that. After the ICC 2022 classification, where increased blast 2 can be considered as an AML and managed like an AML, we use azacitidine plus venetoclax in managing high-risk MDS, followed by allogeneic stem cell transplant. This is a newer drug, magrolimab. What it does is, basically many cancer cells have the capacity to escape from immune cells. So this particular drug makes the cells visible to the immune system, and it activates something called as eat me signal. So the immune cells are able to attack the malignant cell. It's an anti-CD47 antibody. So this has shown response in acute myeloid leukemia and in MDS. That's all from my side. So let us stop here.
Topic is open for discussion. Any questions from audience? Okay. Thank you, madam, for your informative and elegant academic feast. This is very informative for postgraduate students as well as all the pathologists. Actually, it is a very difficult topic for us.
Yeah.
Thank you.
You have mentioned the low grade MDS, right? So any morphological criteria there is to label it as a low grade MDS? Any morphological criteria, bone marrow.
So you are saying if the patient does not have dyspoiesis in the marrow?
Yeah, dyspoiesis, but can
Less
we
than
label-
10% of the cell lineages
Yeah.
is showing. So it is technically very difficult to say. I think a pathologist, hematopathologist is a better person to answer because we rely on, if the morphology is not adequate, we rely on cytogenetics and myeloid NGS panel rather than.
Okay, we'll hand over to the Sumit sir, please.
I mean, this is a tricky area what he asked, but we need to spend time. Obviously, we all spend time on the bone marrow. But in the context of morphology and the history with CBC counts, pancytopenia or bicytopenia, we surely take help of flow. So morphology sometimes is not adequate. We do take help of flow and cytogenetics in these situations before we call it low-grade MDS. And if you see the classical cytogenetic abnormalities and the classical immunophenotype, and the most important dyspoisis is in myeloid series. Erythroid series dyspoisis can be seen in multiple conditions. Could be seen even in megaloblastic anemia or some temporary drugs. But if you see pseudopelvic hue cells or hypogranular myeloid cells, it's almost sine qua non of MDS. But we do have this problem, what you asked. But in these situations, we look at the myeloid cells maturation, erythroid cells maturation, megakaryocytic cells maturation on the flow, look at the patterns of maturation, look at aberrant immunophenotype like CD56 being expressed by neutrophils. If CD56 is expressed by neutrophils or monocytes, we know these are dyspoietic neutrophils. So, and then obviously we do cytogenetics, the classical markers. Thank you.
Thank you, sir. Thank you, ma'am. Thank you very much.
Thank you so much, ma'am. I request the chairperson to felicitate the ma'am.
Thank you, organizing team, for giving me this opportunity to share the session. Thank you, ma'am, for sharing the recent classification updates in MDS in a simplified way with the rare case series. Thank you so much.
I request Jayashri Patel ma'am to felicitate the chairpersons.
Hello. Now it's time for a panel discussion on pancytopenia by expert panelists. Pancytopenia is a very common phenomenon in daily medical practice and one of the most common reasons for consultation from hematologist. And to moderate this session, we are again inviting Dr. Sandeep Nemani sir on stage. I invite all the panelists on stage. Dr. Sumit Gujral, sir, an eminent hematopathologist. Dr. Ruma Manchanda, ma'am. Can I have you on stage, ma'am? Dr. Vijay Ramanan, sir.
Melankari sir is not there. So Dr. Anushri Prabhakaran will take his place.
And Dr. Anushri Prabhakaran, ma'am. And Dr. Arjun Mandade.
Yes, yes.
Beginning.
Okay. So good evening again. We have expert panelists today. All of you know who they are. I'm very small in front of the faculty to moderate this session, to ask questions to them. But for benefit of audience and everybody learning, I take this and I apologize. I'm asking them as a moderator, but they're all teachers to me. So to begin with, these are the panelists we have. And Dr. Manchanda, everybody knows, she's expert hematopathologist and expert in coagulation disorders from Pune. Dr. Sumit Gujral, he's a histopathologist from TMH Mumbai. Then Dr. Melankari has to go because of his commitments. So Dr. Anushri Prabhakaran, she's from Dinanath Mangeshkar Hospital, hematologist. And Dr. Vijay Ramanan from Ruby Hall Clinic, Pune. He's hematologist with us. And we have a medical oncologist as well in the panel discussion on pancytopenia, Dr. Arjun Mandade. He's a local guy, I think, and he'll be there with us for this panel discussion. So to go, we'll just have a little what pancytopenia, how we look at it. Just to simplify the things for you, we'll take it. Pancytopenia means all three cell lines may be affected or two cell lines may be affected. So we'll go by a simple hypothesis of seed, soil, worm, fertilizer hypothesis. So what is a seed? Seed is nothing but the stem cell, which is inside the bone marrow. So seed is a stem cell, which is CD34 positive usually, and which resides and which causes hematopoiesis to happen and all cell lines are produced. Soil is the bone marrow microenvironment. So previously we used to focus only on the seed, but the microenvironment in which the seeds resides is also very important. We call it as niche. And that area, the crosstalk between the microenvironment and the seed is very important for a good hematopoiesis to happen. We call it as bone marrow microenvironment. Then after seed and soil, we know there are some fertilizers, some growth factors are required for proper hematopoiesis to happen. And like the vitamin B12, folic acid, iron, a lot of things are required for the bone marrow to function normally, to produce normal hematopoiesis. And some viral infections like parvovirus infection, HIV infection can affect the hematopoiesis, and insecticides means there should not be any viral infection. So if everything is good, like seeds, soil, fertilizers, no insecticides, everything is done well, so we know the hematopoiesis will be absolutely fine and our HbWC platelet, everything will be normal in the CBC. But if there is some problem, suppose there is nothing growing out of the farm, we call it as aplastic anemia. That means the bone marrow is totally empty. If something grows out of it, but it's all defective, we call it defective hematopoiesis that happens in MDS or megaloblastic anemia. Then something grows out of it, but they're not coming out because there is fibrous weeds or fibrosis that happen everywhere inside the bone marrow. We call it as marrow fibrosis. Then everything is normal. The hematopoiesis is absolutely fine, but there are some intruders which are coming up from outside. Like the patient has tuberculosis and that is causing granulomas inside the marrow, or the patient suppose has CA breast and that is metastasis, CA prostate metastasis to the bone marrow. And this is we call as marrow infiltration. So this is again, we can cause bone marrow infiltration and causing pancytopenia. And everything is normal, but the standing crop is destroyed. Everything is fine with the bone marrow. There are some antibodies against the RBCs. There are some antibodies against the platelets. There is hypersplenism or the splenomegaly is there. We call it as peripheral destruction. So there is no marrow fault, but the fault is in the periphery, not in the marrow. And this all causes can contribute to development of pancytopenia. So with this brief idea, I involve my panelists to have a discussion on few cases so that will enlighten you and give you a good idea of what exactly pancytopenia is. So first, Anu, can you please discuss the CBC?
Okay, this is a 45-year-old gentleman diagnosed to have myelodysplastic neoplasm from outside.
So that is your topic, right? MDS. Yeah.
So his hemoglobin is low at 5.3. MCV is slightly on the higher side. He has normal WBC count, but differential count is significantly altered. Presence of 2% DAS, some shift to left, and platelet count is low.
Okay. You want to put a BC, MCV looks normal, right? Apparently. But you want to say something about this curve of RBC, like the width, RDW, what that suggests, the RDW, what it suggests, like in this, whether it shows there are two population of RBCs, there is an IC
Correct. I am thinking that there may be polychromasia and NRBCs in the peripheral.
Yeah, probably. And other thing is that the patient may have all possible cells in this PS, like it may be large cells, small cells. So the MCV is probably getting nullified with something. So the width or the RDW has increased. So the width of the graph is broader, right? So this suggests that the RDW is high. So is this CBC report complete, Anu?
No, we need a peripheral blood film detailed.
Yeah, so you want a PS. So expert pathologist is always required when you have a CBC. Machine print or machine value, even if you have a 10-part cell counter, your peripheral smear has to be there unless you can't diagnose the patients. So first we'll see the peripheral smear examination report. And this is how it looks like. You want to describe what it looks like?
So there is anemia, there is presence of NRBCs, there is significant variability in RBC size.
Yeah.
There are some macroveilocytes seen.
Yeah.
There are some target cells also
Correct.
seen. And the second picture shows hypersegmented neutrophils.
So any typical thing you think of when you say there is some hypersegmented, a lot of segments are there in the neutrophil.
Presence of macroveilocytes and hypersegmented neutrophils is very much
Any other workup
characteristic
you
of
want to do now beyond
megaloblastic
this?
crisis.
Yeah. So for that, anything you want to, because the patient's marrow was done outside and they told that it's MDS. So the patient came to us to know whether really it's MDS or it's something treatable. So any workup you want to do beyond this?
B12 level and serum LDH there.
Yeah. So serum LDH is sky high. Retic count looks low. It's not there, but it's low. And the HIV, HBCG, HCV, we have to rule out when we have some dysplasia or pancytopenia like this. LFT, RFT is normal. B12 level came low. Fair to give B12 trial and then think of doing MDS, because always we should try to treat the treatable conditions. So diagnosis made here is megaloblastic anemia, though the MCV looks normal and the patient has pancytopenia with some blast on the peripheral smear. After 15 days of B12 trial, patient responded and patient become well. So I shift this case to Madam Manchanda. Can you tell me, like it's been discussed previously, like what are the acquired causes of dysplasia on the bone marrow? When you see bone marrow, what comes in your mind, whether to before labeling somebody as MDS?
Yeah, before we label anybody for MDS can be seen, like it was said in B12. B12 deficiency, megaloblastic anemia is one of the biggest culprits, which shows a lot of dysplasia in all the series. So before labeling anybody, actually MDS is a diagnosis of exclusion more. Of course, there are certain things morphologically like Pelger-Hewitt cells, or you see certain dysgranulation in the neutrophils and the myeloid series, then you can say there is dysplastic change. Or topographically, if you see megakaryocytes sitting right next to the bone marrow trabeculate, then you will say they're not sitting in their normal home, and that is a dysplastic change. Otherwise, all these conditions can be causing alcohol abuse is another reason which can cause a lot of dysplastic changes in the marrow. Besides these medicines, chemotherapy agents, there are dyserythropoietic anemias, and of course, infiltrative disorders. So first, before calling anything MDS, one must rule out all these conditions. Then only we can call it a myelodysplastic.
Yeah, very rightly said, madam. We have encountered patients with pancytopenia. We did marrow dysplasia, and retrospectively, the patient gives history that the patient is on methotrexate weekly. So that's what. So we should be very well versed with the history of the patient. Sometimes GCSF was given for pancytopenia, and then the marrow is done. So there is a lot of dysplasia against inside the bone marrow. So these scenarios, the history, the clinical examination, the patient's drug history is very important. Many times we see consults in the medical college and they don't give us methotrexate history. We do all the workup, and then suddenly after 1 week, somebody says that methotrexate was given to the patient. So
Gutka is one of the reasons which I've been seeing in Maharashtra especially. Gutka chewers have shown changes of myelodysplastic, changes in the bone marrow. And they finally land up maybe in true MDS. Although cytogenetically they don't have any changes, but morphologically they start showing a lot of changes in the cell lines. So I think that is a bridge between a true dysplasia and a acquired
Yeah.
dysplastic.
So the sentence that madam used was MDS is a diagnosis of exclusion. We all young pathologists should understand this. Whenever you want to put your foot and say that the patient is suffering from MDS, you should have 100 thoughts in your mind before you label somebody as MDS, and then only you should label its MDS in all the clinical context. So next case, madam, I will not leave you. So this is 12-year-old boy, female child with pancytopenia, gross hepatosplenomegaly. PS showed normal morphology with mild lymphocytosis. Bone marrow aspirate, normal trilineage hematopoiesis. Nothing was there on the bone marrow aspirate. So for a pancytopenia, hepatosplenomegaly, or any other case per se, is bone marrow aspirate alone is sufficient, or Triffen biopsies equally or more important? What do you want to say?
Peripheral smear or the peripheral blood counts, especially the differential count, definitely tells us which way the marrow will be going. Now, if you have a pancytopenia with a normal differential and hepatosplenomegaly, then you are probably looking at not a marrow problem, but hypersplenism.
Probably, yes.
Because the differential count is normal. Now, in this particular case, I see more of neutropenia. That means relative lymphocytosis. There is anemia, there is thrombocytopenia. So marrow itself has to be seen because here it appears to be a marrow problem. The neutrophils are not there. So definitely marrow alone is not sufficient. You need the biopsy. I always maintain, never do a marrow aspirate alone. Always do it with the biopsy.
And that probably gives an additional information and your confirmation of diagnosis by two tissues, different samples.
Absolutely.
So you confirm whatever you have seen on the aspirate by the doing biopsy. So just madam, can you briefly discuss what you can see in the biopsy of this patient?
So on the left and the right, you can see that there is a cellular marrow on the left side. Depending on the age of the patient, you have to interpret the fatty spaces. We know that with age, the fat increases in the bone biopsy. Babies have 100% cellularities, 80-year-old will have only 20% cellularity. So this is a very cellular marrow with some areas which are showing more fat. We can see that there are some collections, focal collections of, it is granulomas which are seen in this particular case. We can see it's an epithelioid granuloma with a giant cell looking in the middle there. So this is looking like a miliary Cox, or we will report it as granulomas, epithelioid granulomas in the marrow. And of course, do the AFP, but many times we do not see the AFP in the bone marrow. These are, we report it as epithelioid granulomas. Here we can see the giant cell. A loose granuloma is in favor of a Cox lesion, miliary tuberculosis. A tight granuloma, which is sarcoid granuloma, can also be seen, especially in patients who have some kind of a lymphoproliferative disorder.
Thank you, madam. So I'll shift to Dr. Amanan. Discuss causes of pancytopenia with hepatosplenomegaly briefly. Few causes, if you in your routine practice, if you can say yes.
So what Madam said is, I usually divide as either a production problem or a destruction or a redistribution problem, as you rightly did. So you have common causes like malignancy, which could be a lymphoma, specifically involving the spleen, the SLVLs, granulomatous disorders like tuberculosis, and liver disease and NCPF, non-cirrhotic portal fibrosis, should be kept in mind. And that's frequently seen and missed. Storage disorders are rare, but should be kept in mind. Gauchers, we have seen many adult Gauchers and few Neumann-Picks. Autoimmune Evans syndrome per se is, I've not seen many. Felties I've seen. Infective endocarditis is one more other reason where we have seen the splenomegaly and subsequent cytopenias. So these are the common things we should keep in mind. And spleen may be the starting point or maybe the end point of the whole disease. That has to be kept in mind.
Correct. So for students, I just want to say you, whenever examiner asks you about the causes of splenomegaly, causes of hepatosplenomegaly, always divide and rule. Always start with dividing malignancy, granulomatous inflammation, liver diseases, storage disorder, autoimmune. And once you group them, you have 5 things at least to say, because at least you have grouped them together, and then you can say one causes at least. So you have around 5-10 causes that you can speak up. So always divide and then start telling the answers. Okay. So coming to next case, this is 4-year-old male child with hepatosplenomegaly pancytopenia. Child looked apparently stable and comfortable, had PEO, and had received 2 months some treatment with here and there, everywhere hopping. Pancytopenia was there, keep on taking some treatment elsewhere. When we have such history with no much of records, what we think, whenever there is a pancytopenia, we think that the patient might have been exposed to steroids. That is always comes in our hematologist mind, that probably the patient might have received steroids somewhere before coming to us, because 2 months his lingering fever with cytopenias was there. And sometimes he feels better, sometimes he is unwell. So pancytopenia was still persisting. So patient came to us. Pancytopenia was not severe. We can say WBC count was around 1800, platelet count of 60,000, and hemoglobin of staying around 8.59. So kind of borderline pancytopenia, no transfusion requirement. Apparently walking child, came to clinic. PS done. PS showed few atypical looking lymphoid cells, but not very conclusive of blast or any other abnormal cells. Maybe some virocytes we can call. Bone marrow aspirate, similar typical small cells were there, but not very assuring of any etiology, because rest of the hematopoiesis apparently look normal on the aspirate. There is no the megakaryocytes, the erythroids, everything look absolutely fine. So bone marrow biopsy was done for this child, and apparently I think Gujral sir can just discuss briefly about the biopsy.
I mean, before I go to biopsy, can I go to previous slide?
Yes.
If I get this history in my laboratory, I would surely call my pediatric oncologist and tell him two things. Tell him or her two things. One, can you get me any slides pre-treatment? You know, if there is old slides available, mostly they are not available.
Correct.
Because people discard, most laboratories discard the slide. But if any is available, it'll be very informative. Second, in this history, I will surely do, if there's no, like morphology is not conclusive, I'll surely do flow cytometry to pick up MRD. Because if I would like to, in a young kid, hepatosplenomegaly, pancytopenia, what else? First thing comes to my mind is acute leukemia.
Yeah.
It could be autoimmune disorders, but I would like to rule out acute leukemia. I'll surely do T and B MRD tubes. MRD is a measurable residual disease. Okay, next. So now since we have the fine here, we can see the two cores. One is showing cartilage. You can see the cartilage. The other marrow looks fairly cellular for the age. But at a distance, I think there are a lot of erythroid colonies. There is some edema. So it looks like a regenerating marrow. Like, yeah, it looks like a regenerating marrow, possibly because of some treatment-related changes. And can you go back? In my practice, this is very classical marrow of a ALL post-induction.
Yeah.
So when I get in my practice, we have a case of ALL. I'm sorry, I'm taking time. If we have a case of ALL and patient is given chemotherapy and we get patient after 1 month, this is the classical morphology. It's a cellular marrow, tri-lineage hematopoiesis, erythroid colonies. You can see the dark cells look like erythroid colonies, a lot of megakaryocytes. And there's a background shows edema, some new fat. So these are classical features of a regenerating marrow, generally seen after 20 days, 25 days of starting chemotherapy.
Yeah, so with this, sir has just nicely described the biopsy findings. So we don't know what exactly is happening. This is a real life situation that has happened with us in our practice. And this was pre-MRD. It's around 2015 we have seen this patient. So this child, we did flow for ALBS because we thought hepatosplenomegaly is there, pancytopenia is there. Why not to rule out in a child to do autoimmune lymphoproliferative syndrome? And that came negative. Now the child apparently stable. So we just asked the parents to just keep a close follow-up. Every 15 days, we used to call the child and we used to do a CBC and see what is happening, how is his liver spleen, how is his clinical status. And we kept on a close follow-up. And apparently they came to us every 15 days. And after 3 months, when they came, his WBC count was 1.5 lakhs. And his PS was fully studied with blast. Flow cytometry showed it's ALL, B-cell ALL. So apparently the timeline, if you can see the 2 months history of some treatment received was very important. And with this scenario, I go to Dr. Arjun. And the question I want to ask and to open the eyes of everybody, all the clinicians, that how detrimental is used to use steroids in undiagnosed cytopenias or organomegaly cases? What is your comment?
Actually, as sir told ki sir wanted to see the slides before 2 months. Actually, this is the answer because steroid is a double-edged sword. It will give benefit also. It is harmful also. It has benefited for 3 months. That's why you have followed it for 3 months. The thing is, the most importantly, most of the physicians and pediatricians, they're tempted to use the steroids
Correct.
as soon as they see the cytopenia,
Cytopenia.
because they always feel it, we will kill the autoantibodies first and we'll just settle the patient.
Other thing is, you have to just, they want to reduce the fever as fast as possible of the
Yes,
patient.
yes,
So one
yes.
shot of Dexa is always given, not like at any level, like it's been used. And after COVID, I'm seeing that they have rampant usage of steroids in all cytopenias and fever patients.
Yes, so use of steroid should not be it has to be used once the diagnosis is final, it is confirmed, because it will alter the bone marrow as well as it will alter the molecular workup, and prolonged use of steroid can have refractoriness in the
Correct.
ALL inductions also.
Correct.
And
So
again,
outcome also
outcome will be poor. We will be delayed in the accurate
treatment.
diagnosis.
Correct. So it's very good point he has made. So outcome will be poor, the diagnosis will be delayed, and the precious time of patients starting proper treatment is gone. You take any hematological malignancy other than myeloid malignancy, you name myeloma, you name lymphoma, you name ALL, everywhere steroid is a major backbone of treatment for hematolymphoid malignancies. So without diagnosing cytopenias, the cause or the organomegaly lymphadenopathy, we suggest, I think, never use steroids in undiagnosed cytopenia patients. So coming to next case, this is 70-year-old female patient with weakness, known case of CA breast, treated 4 years back, HB 7.4, WBC 1800 with neutrophil of 48%, platelet of 24,000, LFT, RFT normal, no organomegaly in the patient. So Gujral sir, you want to comment on the aspirate and the biopsy of this patient?
So this is straightforward carcinoma. The biopsy shows nice desmoplasia. You see the background fibrosis? This is very classical. So my point is sometimes aspirate and biopsy do not correlate. You have one giving tumor, other giving not a tumor. So you have to relate together. If one is calling positive, it is positive.
Yeah. So it's classical metastasis in the marrow because the background history of CA breast. So again, I go to Dr. Arjun. What are your DDs in a patient of pancytopenia few years back treated for some malignant condition?
So first of all, the recurrence.
Correct.
Whatever is the primary, it may be solid or liquid. It may be leukemia, lymphoma, or any solid malignancy. Second is the second malignancy. It can always happen the second malignancy in the patient, which can have a pancytopenia. Third is the pancytopenia secondary to solid organs. Like I would like to answer the second question also.
So before we move that, can you just tell us some in brief about the second malignancies, or the suppose a patient treated for solid tumor after a few years develop pancytopenia, MDS,
Yes.
AML. So just tell them about the chemotherapeutic disadvantage that can happen in few patients after treating for solid tumors, and they can get AML later on,
Yes,
or the
yes.
MDS later on.
So the alkylating agents and few other chemotherapy medicines, which are used for the primary malignancy, like in sarcomas also, can hamper the bone marrow later on and can have MDS and
So we call it
leukemias.
as therapy-related MDS or AML, right?
Yes, yes, yes. So this is important to know the previous history, the use of those drugs, how long the drug has been used, what all drugs patient has been exposed to before, and the risk according to having the second malignancy and subsequently the pancytopenia.
Yeah. So, but it's quite rare, I think, to develop a second malignancy, but it happens sometimes. So what are the common encountered tumors that are diagnosed on bone marrow metastasis?
So basically, we are usually seeing the routine solid tumor malignancies are most common is lung, which is 39 to 59% lung malignancies. Usually patient come up with a simple cold, simple cough with a back pain, low back pain. And if we do the scan, we will see the nice lesions in the spine. Then the breast malignancies, colorectal malignancies, melanomas, RCCs, prostate, all these are more prone to, catch the bones first or the most common.
Prostate also, you told,
Yes,
right?
yes,
So,
yes.
so we had one patient, young middle-aged female, 40-year, asymptomatic borderline pancytopenia. I was like thinking whether to do a marrow or not for the borderline pancytopenia. We did marrow, we found metastasis. And the PET scan was done that showed around 0.5 centimeter nodule in the breast. So she had primary CA breast metastasis to marrow. She also didn't know clinically also it's not palpable, the breast nodule. But she had presented with metastatic CA breast. So that can happen sometimes, like in the this thing also.
Yes. So nowadays in our practice, whenever pancytopenia case is there, first we are doing the marrow rather than doing the PET scan, because PET scan is a later stage. First we have to find out why there is a pancytopenia. Out of 10 marrows, at least one case you will get metastatic deposits.
yes.
And then we do the
For primary
immunohistochemistry, and then retrospectively you find out, oh, this is a lung.
Correct. Yeah. So Anu, this is for you. 46-year-old male, chronic alcoholic, fitness for hernia surgery, spleen 4 centimeter, borderline pancytopenia with good amount of neutrophils. liver dysfunction, borderline, albumin low, PT INR mildly deranged. So how will you evaluate this case and how will you give fitness for surgery?
So the first possibility is that he has cirrhosis with portal hypertension.
Okay.
So we'll ask for an ultrasound abdomen to look for what is the size of the
there,
liver, what is the
CLD
spleen
portal
size, what is
hypertension
the portal
spleen is
vein
there.
like.
Yeah.
And
So
upper GI
marrow was done for confirmation of hypersplenism, and upper GI scopy showed varices. So it's CLD portal hypertension. What about fitness for hernia surgery?
labs. Can you go back?
Yeah.
So hernia surgery will be under spinal. So
So
ideally,
you can guide them. Spinal bar GA, anything is fine with the surgery.
yeah. So better to go for a GA rather
Yeah.
than.
But that too, avoiding hepatotoxicity. Sometimes CLD can decompensate post surgery. So gastro also need to be involved before we give fitness. But platelet count is and INR looks safe for doing a hernia surgery, right? Okay. So because it's an hypersplenism, we can give fitness for surgery from our side at least. Spinal requires little higher platelet count, so better to do it under GA. So diagnosis comes as hypersplenism. So it's a peripheral destruction kind of thing. So Dr. Ramanan again, 41-year-old male, weakness, gum bleeding, ecchymotic patches, HB low, WBC count looks normal, but 92% blast plus promyelocytes, platelet 10,000, PT APTT gross the abnormal with fibrinogen of 70. So the first question to you is, how will you proceed in this case? Second, how important is to urgent diagnosis and treatment in this case? Any thoughts?
This is a medical emergency, and first thing we say is, first of all, book our own cryoprecipitate and the platelets and send for a PML RAR alpha to or a translocation 15-17. The PCRs take now hardly 24 hours, less than 24 hours we
Correct.
get a report. So we usually transfuse before we get the
So
reports.
patient
also,
with leukemia presenting as DIC, right?
as DIC would
Yeah.
be
And bleeding.
with bleeding.
Yeah.
That's the only one where you have so low
Correct.
because of fibrinolysis. There's a low fibrinogen.
So what is that low? What is that disease? Just put the name
acute,
also.
acute myeloid leukemia with translocation 15-17.
Correct. So APML. So this is the dreaded word every hematologist has. Like night time, 12 o'clock, suspected APML, we jump from our bed because that is the only thing as an emergency we have to manage in hematology.
Even our residents know it now. So,
Sir Gujral, sir, please discuss the bone marrow findings, IPS, and discuss about some advanced test in this.
Just two things here. We have short of time. These faggots are not seen in 80% of APML. So postgraduates and young pathologists, please do not look for phagots. So it's something similar in hairy cell leukemia, you don't get hairy projections. So you have to look for the other characters of the cell, nuclear chromatin, cytoplasm, granules, there are multiple other things. Second, this is classical APML, but you can get hypogranular APMLs. So you have to do myeloperoxidase stain. This is one leukemia where myeloperoxidase will be
diagnosed
+5, +4. Very strong. The slide becomes black. It is very, very strong. Hypogranular APML can look like monocytic leukemia. So MPO is important. I think rest is fine.
Yeah. So biopsy also correlating. Flow cytometry, can you put a word? Like the flow panel CD13.
Time is over.
Yeah. And if the fish is confirmatory by translocation, 1570 has come positive. So coming to last case of today's, a 12-year-old girl child with short stature and weakness, history of hyperpigmented patches, congenital single kidney on ultrasound with thumb anomalies, and pancytopenia with lymphocytic predominance. This is the picture of the child with thumb abnormality. Manchanda madam, just briefly if you can discuss the biopsy findings.
Child clinically is also very, very typical of inherited marrow failure syndromes, probably Fanconi's. The marrow biopsy is totally acellular with increase in fats, hardly any hematopoietic cells. With the extradactyly, it goes in favor of bone marrow failure, inherited bone marrow failure syndromes, and must do stress cytogenetics to confirm. Anyway, it's basically a marrow failure, aplastic anemia, which is inherited.
So straightforward aplastic anemia. Again, diagnosis has to be done on biopsy, not on the aspirate alone.
No, never.
So Anu, can you tell us further workup you will do fast? Probable diagnosis, approach, inherited bone marrow versus acquired. Just tell fast whatever you want to say about all this.
We will do 2 tests, chromosomal breakage analysis and next generation sequencing. That treatment is with bone marrow transplant.
Yeah.
Allergenic
So because
stem
it's
cell.
a inherited marrow failure syndrome, so usually we can give androgenic steroid for some time, but curative treatment will be bone marrow transplantation. So with this, we come to end of this panel discussion. If you have any doubts, queries, panelists are there with you. You can ask them anything. Don't ask me anything.
Thank you. Thank you all the panelists and Dr. Nemani sir for this precise and scholarly panel discussion. So all the panelists, please be on stage. I request Dr. Umesh Kanade sir to felicitate all the panelists and Dr. Nemani sir. Now I invite Mr. Anil Desai, who is area manager of Neon Coding. Neon Coding is one of the sponsors for today's event. Mr. Anil Desai will talk about recent launches of Neon Coding. Mr. Anil Desai, please come on stage.
Good afternoon, doctors. First, I'd like to thanks to given the opportunity due to the short of time. We are not going to any presentation. Just we want to introduce ourselves. Nihon Godon is established in 1951 in Japan. We are the committed to be improving health solution with advanced technology, and we are fighting the disease with electronics. Neon Codon, we are the leading manufacturer in medical electronic equipments with hematology analyzer and point of care and mini monitors. In Neon Codon, we have two divisions. One is working in hospital instrument and second is IVT, that is dealing with hematology analyzer. So in hematology analyzer, we have 3-part and 5-part analyzer. In 3-part, we have 1301, which is a CBC analyzer, and 1305, which is very innovative and advanced CBC with ESR analyzer. Also, we have 5-part, that is MEK 7300, MEK 9100, and we have advanced with Dynascatter flow technology, that is 9200 with retic count. So this is our hematology products and IVD. And I really thanks to being heavy patient, listen to me and interest shown, and given the opportunity to us to highlight our actually products. And thank you for the Latur Medical Association.
After discussing this pancytopenia, we are proceeding to discuss a diagnostic approach to acute leukemia. To chair this session, I would like to invite Dr. Shirish Patil sir, a senior physician from the city, and Meenal Patil madam, senior pathologist from Solapur. For this session, I would like to invite Dr. Ketki Kelkar ma'am.
Dr. Ketki Kelkar ma'am is a practicing hematopathologist and molecular pathologist with a great 16 years of experience to her credit. She is the director of Anjali Diagnostic Pathology Laboratory, a hematology-based lab which specializes in bone marrow reporting. She heads the pathology department at Gene Path Diagnostics, which specializes in NGS-based testing. She has been a faculty member at various hematology and oncology conferences and published various papers in molecular hematology in international journals. Please welcome Dr. Ketki Kelkar ma'am.
It's actually good to see so many people at this time. I think all of us have reached our saturation point, so I will try to sum it up. This topic actually cannot be finished in 20 minutes, but I will try to. Okay, so we all know as the WHO classification keeps on getting updated, the morphological criteria lose their relevance and the genetic criteria get a lot of attention. So in all this, if the morphologists and the geneticists decide to stay as friends or enemies, we don't mind. But the clinician has to make sure that he needs them both because he wants a diagnosis for the patient, not only a diagnosis, but also prognostication of his acute leukemia. So he has to befriend them both. Okay, so having said that, if the clinician decides to give all this clinical history to the pathologist, what he has to make sure is that he has to send a fresh finger prick smear or a direct smear to his hematopathologist so that he can look at the slide, tell him whether he can see blast or not, and then further advise bone marrow testing. He also needs to tell the pathologist if the patient has been started on steroids, because we know as a lot of discussion has been taken place, if you give steroids to the patients, the blasts disappear. So it may take some time for the pathologist to spot a blast before he tells, yes, it looks like a case of a partially treated ALL. At the same time, I would like to say something else is that we see many of our patients diagnosed as MDS, AML arising from MDS to be actually clinically asymptomatic or just mildly symptomatic. So we know that the WHO classification 2022 for B-cell ALL, T-cell ALL, and at the same time AML has undergone a lot of changes. It means that a lot of genetic criteria have been added, lot of gene rearrangements, gene translocations, like lesions and all have been given a lot of preference. You can see all that. Okay, and the ICC classification also classifies AML, there's a hierarchical classification, like AML with recurrent genetic abnormality gets an upper hand over MDS AML with a mutated TP53, which also gets an upper hand over AML MDS with myelodysplasia related gene mutation. This gets an upper hand over cytogenetic abnormality. And the last, when you do not find anything after doing a comprehensive genetic testing, you get something called as AML NOS. Okay, so what are the changes? The most important change is a change in the blast count from 20% to greater than 10% in bone marrow or peripheral blood for AML with certain defined genetic abnormalities, except AML with BCR-ABL fusion and AML with SEBA mutation. The key changes in AML myelodysplasia related include removal of morphology as the sole diagnostic criteria, and the cytogenetic criteria are updated, and introduction of a mutation-based definition defined by a set of 8 genes, and these genes can be done or detected by using NGS-based methodology. So coming to diagnosis of acute leukemias, yes, I mean, cytogenetics, NGS-based testing have definitely taken over, but we need to still remember that morphology, cytochemistry, and immunophenotyping still play an extremely important role. So a patient of acute leukemia, when you look at the hemogram, the patient may have anemia. In fact, we have seen many patients where anemia is the only presenting symptom and the TLC and the platelet counts may be normal. Okay, the TLC is usually, it can be low, it could be normal, or it could be increased also. High WBC count in B-cell ALL is considered to be a bad prognostic indicator. The platelet count is usually low, but it could be normal or even increased in certain ALL with, for example, inversion 3 and all. They may have a normal or an increased platelet count. Note that, in all these patients at diagnosis, usually the platelet count is the first to reduce, and whenever the patient is going to relapse, similarly, the platelet count is also the one which starts reducing. So if you have a patient who is a known case of ALL or AML, he's following up with you regularly, and then you see that the platelet count is reducing slightly, you make sure to tell your hematpath, please see the slide properly. I want to see if there are blasts, in the peripheral smear. I again want to highlight this is please send either the patient to your hematopathologist or give a direct smear to the pathologist. You don't want the smear to look like this. You want to, have a look at a better smear. Okay, so once the pathologist tells you all, yes, there are blasts in the smear, you decide to do bone marrow testing. And as has been discussed, you need to do both bone marrow aspirate and biopsy. Please do not use stainless steel needles because they are pathetic, they are extremely painful, and there are a lot of artifacts which get introduced. So only use a Jamshedi needle, which is blue colored needle. In adults, use a 11 number needle, and in children, you can use a 13 number needle. For pediatric patients also, I prefer using an adult needle. So if a 13 number needle is not available, you can use an adult needle also. So when you're removing the bone marrow, obviously you're going to make some slides, smears on the slides. So before you put the marrow on the slide, make sure you clean the slides properly with cotton. And if they are brand new slides, make sure you give it to your technician. So this is for the pathologists who are doing marrows. Please make sure to give, if they are fresh slides, first clean them in soap. Ask your attendant to clean them in soap and water, again in normal water, and then use them, because sometimes no matter what you do, you put gym sand, all the slides just don't get stained. Always make direct smears. Don't use crush smears, because if you use crush smears, it can get extremely tricky. Like for example, for not for us, but for someone who is a novice, he may actually confuse an erythroid for a plasma cell, and such blunders have happened. So please make sure to make direct smears. Don't make crush smears from the anticoagulant tubes. Make very good imprints. Like for example, if your bone marrow is a dry tap, okay, you have to tell the clinician, because he's sitting on your head, I want a diagnosis. So in that case, make imprints, because they're going to help you. So what do you mean by making good imprints is that when you're taking the biopsy, please put the biopsy on a slide, and आपण पोळी लाटतो तेव्हा ते जे लाटणं असतं ना, जसं वी roll it on the slide, a similar way, roll the biopsy on the slide, so that you can get 90% diagnosis only on the imprint. If you're suspecting a patient who has acute leukemia when the pathologist has told you about the blast, make sure to collect the samples both in EDTA and in heparin, because in EDTA you can do immunophenotyping as well as NGS-based technology. Remember, all NGS-based technology is PCR-based. So any PCR-based testing you have to collect in EDTA tubes. And in heparin tube, you will also collect, because for acute leukemia diagnosis, you always need a karyotyping or a FISH-based testing, depending on the hematologist's choice. Make sure to collect that refined biopsy in Bowen's fluid only. Now, this is the Bowen's fluid, which is a yellow-colored fluid. It's a mixture of formalin and picric acid. It gives excellent morphology, and it is not very costly also. This whole bottle, it is 950 rupees per bottle. You can use it for around 300 tubes. So it means that it is really 3-4 rupees. You get the Bowen's fluid, but you get an excellent morphology in Bowen's fluid. Please, please do not collect your refined biopsies in formalin, because then, I mean, for me, it has been a nightmare. It is very difficult. It is literally impossible for me to report refined biopsies which have been formalin fixed. So make sure that the take-home message today is, kahi पण करा, पण if you're doing the marrow, Bowen's fluid ची बाटली ana, this Bowen's fluid you can get even on India Mart. I mean, it is easily available everywhere. Or if the clinician is doing it, please give him Bowen's fluid so that he collects the biopsy in Bowen's fluid only. Make sure this Bowen's fluid does not come in contact with the aspirate slides, because if it comes in contact, then no matter whatever you do, I mean, not even God is going to help you, because the staining becomes something like this. You cannot appreciate the morphology, and it becomes extremely difficult to give a diagnosis. So make sure that you keep the Bowen's fluid away from the aspirate slides. And also, if you're suspecting a patient to have leukemia, make sure that you send complete clinical details and a fresh smear, as I've mentioned already 3-4 times, and also the immunophenotyping to be sent to the lab within 48 hours. Now, this is the morphology. You can look at these wonderful plasma cells, which you can see on a refined biopsy, which has been taken in Bowen's fluid. As compared to this is a refined biopsy in formalin. You cannot identify the erythroid precursors, myeloid precursors, nothing. And then it becomes very difficult. Now, this is a refined biopsy when you are using a stainless steel needle. In our hospital, sometimes if the Jamshedi needle is not available, we have no choice but to take a stainless steel needle, and we get something like this. Lot of crushing artifact, and the marrow spaces look empty. I mean, we think probably it's a plastic, but nothing. When you're putting the stainless steel needle inside, all the marrow is coming out. Now, this is an AI level generated. This is my husband, and this is an AI generated Vijay Ramanan. This man looks much smarter and better than him. What I want to highlight, y'all, is that we still don't have AI to a level where whatever Kachra slides are given to us, the AI can convert it into good slides. I mean, if that comes, we don't have to beg our clinician ki अरे चांगल्या बुएन्स मध्ये घ्या, असं करा, तसं करा. Right? So till AI comes, we have to tell them that do follow this protocol. Now, when you're doing a bone marrow aspirate, if it is a dry tap, it is more likely to be ALL, because lymphoid blasts are sticky. This is not 100%, but in majority of our patients, if it's a dry tap, you're trying extremely, you're using all your strength and all, and nothing is coming out, they are more likely to be ALL blasts. The few exceptions are AML, which have myelofibrosis, or AML M7. Again, if it's a dry tap, please don't make smears. Even if you're getting in 0.5 cc, put everything in the EDTA tubes, okay? Because even with 0.5 cc, you can do a flow. AML blasts are usually associated with plasma cells. So if you have a peripheral smear, direct smear, which shows rouleau formation and blast, it is more likely to be AML. Obviously, if you know that the patient has acute leukemia, you're going to use MPO stain. So in this MPO stain, please make it on your direct EDTA smears, but not on imprints, because it gets extremely difficult to appreciate them. And make sure that the bone marrow staining is done within 24 hours of procedure. If you are having a problem with Leishman stain, you can also add Giemsa stain after Leishman stain. Now, is bone marrow required for diagnosis? If the blast count is greater than 2000, a marrow is actually not required. But for us, what we do is that if the blasts are greater than 40%, 4000 microliter is also okay. The greatest advantage of bone marrow aspirate and biopsy is that, you have a lot of, if there are not adequate blasts on the smear, on the peripheral smear, you can always do a lot of testing, which I said, immunophenotyping, NGS, karyotyping on the marrow aspirate. Fish-based testing sometimes works better on marrow aspirate, except in cases of myelofibrosis. And the advantage of refined biopsy is that if your aspirate is a dry tap, you can always do IHC and subsequent fish-based testing on that refined biopsy, and to look for the degree of myelofibrosis, because fibrosis is an independent prognostic factor in both ALL and AML. Cytochemistry, MPO, it is a mandatory criteria. Please do it on your bone marrow aspirate slide and use a fresh stain, because if you're using an old stain, it can cause a lot of precipitate and it will be very difficult to appreciate. MPO by flow cytometry, if it is weak positive, MPO by flow, it cannot be used as a criteria because it can be very non-specific. And as Dr. Gujral said, MPO strong positive in APML, positive in AML, and here this is a control which is positive, and this is an ALL blast which is negative. So MPO stain can give us many things. I will not go into the basics of flow cytometry or immunophenotyping, but make sure to collect your samples in EDTA or heparin tube. Could be a bone marrow or peripheral blood, and it should reach the lab within 48 hours. And if it is possible, if you can send direct smears, that is also good. Now, flow cytometry in acute leukemia, you run certain set of markers, you divide it into B cell and T cell ALL, which also has subclassification, which actually doesn't hold much relevance in the age of genetics. Of course, before you go any further, you classify it into ALL or AML, you need to know the lineage markers, which are here. So this is a flow cytometry where the blasts are CD19, 20 positive, 34 positive, HLA-DR positive, 10 positive, cytoplasmic 79A and negative for myeloid and T cell markers, and you can give a clear-cut diagnosis of pre-B ALL. Cytogenetics, again, karyotyping is a mandatory criteria, and all the classification of acute leukemia is karyotyping based, which can give an idea of the hyperdiploidy, hypodiploidy, translocations, and so on. The disadvantage is that it has a longer TAT and you need metaphases. So sometimes no yield is possible at that time, and then you have to resort to fish-based testing. Fish-based testing is also a mandatory criteria, helps in classification of acute leukemias. Certain cryptic translocations which cannot be detected by karyotyping can be detected by fish. Molecular testing, as we know, has completely changed the way we look at hematology. Like, for example, if you have a myeloid NGS panel, we can find out the type of DNA mutation and the fusion transcripts, and also classify the variants into various subtypes. And at the same time, we can also suggest relevant therapies which are available for this variant. But having said that, use your molecular tests wisely. Think twice about it. I would like to finish with two cases of a 13-year-old male who was diagnosed with pre-B ALN and who had taken steroids for a few days, and hence the peripheral blood showed only 1 to 2% blasts. The beauty of real-time PCR-based testing, prognostics testing, where only 1 to 2% blasts were there, but it was positive for AML, TEL AML translocation. And we have developed a custom PCR-based test for BCR-ABL minor, PML, RARA, micro, and all this can be monitored. Okay. I think I don't have time for the second case. I think time is up, right? Is the time up? Yeah. So in the end, we want happy doctors and we want happy faces. So this is the happy face of Prabhas. And I would like to summarize by saying, please choose your tests wisely. The hematologist needs patient affordability, faster TAT, and all whatever is available in-house needs to be taken into account. Please counsel your patients because all these genetic tests are costly. And for both ALL and AML patients, what we do is karyotyping plus NGS DNA and DNA RNA, whatever is possible, and make sure that the clinician discusses his cases with both the geneticist and the morphologist, which is required for better patient management. Thank you. Any questions? I don't think we have time.
Thank you so much, ma'am, for this informative and engaging session. I request our chairpersons to felicitate Dr. Ketki Kelkar, ma'am. I request Dr. Swapna Utikar, ma'am, to felicitate our chairpersons.
Now, after this diagnostic approach towards acute leukemia, now we will have a session on clinical aspects of acute leukemia. And to enlighten us in this regard, we are inviting on stage an eminent hematologist, also known as God of Thalassemia, Dr. Vijay Ramanan, sir. And to chair the session, we are inviting on stage Dr. Anjali Kulkarni, Professor, GMC Sambhajinagar, and Dr. Sheila Gaikwad, ma'am, Associate Professor, SRTR Medical College, Ambazogai. Dr. Vijay Ramanan, sir. He is the chairperson, head and founding director of Bone Marrow and Stem Cell Transplant Unit at Ruby Hall Clinic, Pune. The chairperson at Yashoda Hematology Clinic and director, Red Cross Thalassemia Center and MVR Welfare Foundation. Dr. Ramanan is an accomplished clinical hematologist and bone marrow transplant physician with a 24 years experience in hematology and bone marrow transplants with more than 370 transplants done at Ruby Hall Clinic, Pune. And he has made significant contributions in research, which includes pioneering treatments for thalassemia and leukemia. To his credit, he has many awards, including National Quality Excellence Award and God of Thalassemia Award. He also has been featured in Forbes India, April 2021, as Leaders in Healthcare, the Distinctive Excellence. So I request Dr. Ramanan, sir, to please go ahead with the session.
Thank you. Dhanyavad, Dr. Kanade. So I heard a lot. I mean, after many years, we spoke to each other. So Latur has many, many things. So one of our thalassemia patient has in fact joined GMC Latur. He's in his second year. So he'll be meeting Dr. Kanade in his path posting. So there are 17 thalassemia majors who joined MBBS in the last 2 years, and 7 of them have joined IIT, including one in IIT Indore in computer sciences. So 2 of my patients have become designers from National Institute of Design in Ahmedabad. One of them is in US, and many have become lawyers and MBAs. So coming to acute leukemia, Madam Dr. Ketki has finished majority of my portion, and Dr. We in the pan-cytopenia discussion, we covered majority of it. So acute leukemia is basically a result of series of mutational events which occur, so which prevents there's a maturation defect and there's a proliferative advantage to the cell which has already got a maturation defect. So principally we divide into ALL, AML, and then you have the combined in between. So so these are the usual classification. Eventually what happens is in the bone marrow, these cells which are proliferated escape into the circulation or go into the lymph node as such. So just coming into the epidemiology, the ALL is usually in the predominantly in the younger age. It's better to be in the younger age. So if it's in the elderly guy who develops a ALL, we always tell our patients ki छोटे मुलाचा आजार मोठ्याला झाला. So it becomes more easier to tell the patient also the prognosis is not good. Similarly, AML is usually a T-ALL may be in the adulthood, but the B-ALL has to be in a bacha or a child. AML is usually in the middle age, and the elderly beyond the age of 60 have a very poor prognosis with AML. So what is the incidence of AML? So of leukemias as such, both of them have a higher incidence of male. So I don't know why males are selected by nature for leukemias, but that's the thing. There's a 2% disadvantage for of us being males as far as leukemias are concerned. The average global standardized rate of incidence is 5.4 per 100,000 kids or people. I don't know whether you can see it. This is from the WHO site. You can also have a peep. So this is the total number of lukes. That was 2022 data, 2,27,000, out of which India is luckily second after China at 49,000. China is 81,000 as such. So important to remember, I think the diagnosis of lukes is a bit less in India. That's why we are behind them. Probably we'll cross them before our GDP crosses them. We'll cross in this number, thanks to the use of insecticides in our farming. So what are the risk factors as such? So there are genetic and environmental risk factors, genetics which you cannot control, and which epigenetic risk factors, somatic fusion, and some inherited genetic susceptibility, which is very, very rare. Epigenetic per se, my MD guy, Dr. Yagnik, has been doing a lot of work in it in India, pioneering work in epigenetics. And that we cannot control, which was 100-year-old. But today, the pregnant mothers can have probably a more nutritious diet to prevent lukes from forming. Environmental include ionizing radiation. All the sugar intake also, I think, should be kept in mind. And also the insecticide use. Number one is Roundup, or it's called Mera 71, which your farmers are using left, right, center. And if you have farms, you can ask your guys who are farming for you. This guy called Knudsen was a Swedish guy who came with this theory of two-hit hypothesis. Now there are three-hit hypotheses. So two-hit means the first one is usually a pro-cancer gene. Now there are about 100 people here. Out of these 100, around 2 would be having a pro-cancer gene mutation. But those 2 will not get cancer till they get the second mutation, which is in the anti-cancer gene, which I think Anushri covered in P53. TP53, that's a usual common mutation which gets defective. After that, the clonal advantage starts and the tumor starts forming. Now, don't look at this busy slide. So this is the third three-hit thing. Look at the right side of the whole thing. So what happens is once your patient goes into remission, that whole clone gets another mutation. And that mutation leads to the relapse. So there are many people who ask you, कशाला झालं आपण तर सगळं उपचार संपवलं होतं. So always remember there's one more genetic defect which has been added. That's why the tumor escaped. Now this methyl glycol. If you go into biochemistry, it's been there for many donkey's years. It's been there, but it's very important for us because 60-70% of our population is pre-diabetic. 5-10% of our population is already diabetic. So remember, whenever there's a lot of glucose, a lot of fructose, there are many people who say fruits are very healthy. Remember, fructose ultimately goes to liver and it's metabolized to fat, and the number one contributor of methyl glycol in our body. What methyl glycol does is basically it reduces the apoptosis of the bad cells. So remember, all the tumor cells fail to apoptose because of methyl glycol. So that's very important to remember. This may be one of the reasons why we are getting a lot of leukemias as such. Clinical presentation, madam had covered a little bit, but remember there are only 3 cells in hematology. Very simple. RBC, WC, platelet. So RBC low, anemia, WC low, fever, and platelet low, bleeding. So these are 3 symptoms you have to remember. If WBC is proliferate, you will have lymph gland swelling. Those are things to be remembered. So physical examination, hepatosplenomegaly, lymphadenopathy, sternal tenderness. You can have gum hypertrophy. All those things you can see. So looking at Dr. Ketki's cartoon, I decided to put 1 or 2 cartoons. So this is one of the these are the symptoms that you have to remember as students. And remember that if a child is not looking well, do not give steroid and try to prove the diagnosis, because ultimately it may be something like more life-threatening than you think. And in acute myelogenous leukemia, as Dr. Gujral said, don't look at faggots, but at least try to look for the OR rods, which are not the right fishing rods, but the rods which are there in the AML cells. So always remember, lymph node, think of ALL, think of AML monocytoid. If it's a mediastinal mass, think of TALL or AML with monocytoid differentiation. If there's a skin infiltration, think of acute myeloid leukemia monocytoid, but elderly, you look for cutaneous T-cell lymphoma. If there's a pro-apoptosis, think of Burkitt's. Like we had a slide in the previous pan-cytopenia discussion where there was a lot of bleeding. We think of AML M3, APML, acute promyelocytic leukemia with the previous classification. If you have CNS disease, look for ALL, gum bleeding, AML M3, and hematuria, you look for, in fact, gum bleeding and hematuria, you look for APML or acute promyelocytic leukemia. Diagnosis and classification have been covered. Prognosis, she mentioned about it. So in ALL, it's very important to remember age is very number one. Age less than 1 year and more than 10 years is a bad prognostic sign. And second is WBC count at presentation, then WBC count at day 8 after steroids. Then you have chromosomal abnormalities, CNS involvement, and being a male. So that's a bad thing. So prognosis in male depends on what is the translocation. ELN is European Leukemia Net. You do not remember, it's called 1, 2, 3. So these are the 3 things which is available online. So how do we treat? We treat our ALL with approximately 2.5 to 3 years of treatment. So depending on what is the count, we have a phase of induction, we have a phase of consolidation, reinduction, and ultimately maintenance. So we look for the minimal residual disease or measurable residual disease. And if it's less than 10 to the power of -4, we continue on the same treatment. If it's increasing, we recommend salvage chemotherapy followed by transplant. In AML, the treatment is getting more and more complicated. The slide is totally busy. So most important thing is the first 1 month is 7+3. You may add many things. So if you have a mutation which works for venetoclax, you can add venetoclax. There are few mutations where fludarabine and cladribine are working, so we can add that. Ultimately, you consolidate. Remember, in the good group, you will get away with chemotherapy. In the intermediate group, you'll get salvage around 50%. In the poor group, you'll be able to only get 20%. So in the poor AML risk category, you need to plan for transplant at the earliest. In elderly AML beyond the age of 60-65, there are very few options. Dr. Anushri covered about azacitidine venetoclax in her presentation. So that's the standard line of treatment, and you can give it. Remember, we are trying to control the disease, not cure the disease in a elderly AML. So that's very important. Quality of life is the first target. So what has happened with all the treatment? Survival in ALL has fantastically gone up. You can see the slides just going up towards the top, near 90% with the present treatment as such. In India, this may not be true because our patients come a bit late. Steroid is misused or used too much, and that's why probably our patients are a bit steroid refractory. And in AML, less than 60 years, the result is going towards 60%, and more than 60-65 years, you can see the result is still dismal. It's at 20%. So what are the barriers for treatment? First of all, pre-diagnosis. If the patient comes with joint pain, we treat with, for example, our myelomas go to orthopedician, they get a lot of NSAIDs, ultimately develop renal failure. And so similarly, our patients go to the wrong people. So remember, physician is the first, or physician, pediatrician is the first point of contact. Pathologists are very, very important because the slide will tell you 1,000 things which the patient will not tell you, and that you can tell to your physician or the point of contact, or even the GP. That's very important. And diagnosis takes a bit of time, and ultimately treatment is expensive. Luckily, in our state of Maharashtra, a lot of things are covered under government schemes, but ultimately, and there are a lot of trusts which are helping in treatment as such. So remember that all these are available, but they may not be available at the point when the patient wants, but they are still available. So these are the barriers in treatment. So ultimately, remember that pre-ALL in standard risk category in a young guy, you will get around 80 to 90% result. APML would have around 90% if you survive the first 10 days. First 10 days are horrendous because in the first 10 days, the patient may bleed or may clot at the same time. And that's very dangerous. Inversion 16, that's one of the recurrent cytogenetic abnormalities without any FLT3 or any other mutation would also have a good prognosis. Intermediate risk AML has 50% long-term, so you may need transplant in 50% of the patients. Hematopoietic stem cell transplant is curable for the poor risk AML as such. So I would like to end by saying, remember we are in Maharashtra and all the diagnoses are very easily accessible. Maximum is 6-7 hours of travel. And we have one of the highest densities of hematologists and oncologists, and that is going to only improve in the next coming few years. So all therapies are accessible, though may not be affordable at the present time. So even transplant has become more affordable. At our center, Ratan Tata Trust, and many NGOs are helping us. So if you need any help for thalassemia or leukemias, you can contact us at this number. Thank you.
Thank you, Dr. Ramanan, sir, for sharing your wealth of knowledge with us. Now we are going to announce I request the chairpersons to felicitate Dr. Ramanan, sir. I request Dr. Hanmante sir to felicitate our chairpersons. I request all the participants in poster competition to please be here till 5:30. We are going to announce the prizes soon.
Our next session is very interesting from clinical as well as pathological aspect. It is lymphoproliferative disorder. I will take a privilege to invite an esteemed hemato-oncopathologist and students' favorite lymphoma teacher, Dr. Gujral sir, who has made his star mark in the field of hemato-oncopathology. Sir is a professor in the Department of Pathology, Tata Memorial Hospital, Mumbai. Sir is also a member of editorial board of Clinical Cytometry, Indian Journal of Cancer, Indian Journal of Pathology, Microbiology, Hematology, Blood Transfusion, and many more.
This one. Yeah. This one. Case me.
To chair this session, I would like to invite Dr. Satish Mangal sir, practicing pathologist Solapur, and Dr. Abhay Raikhelkar sir, associate professor at Ashwini Medical College, Solapur.
File name Sumita.
Yeah. Yes. I will show from beginning.
Thank you.
Just for photo.
Okay. You can't make that. Can I start? Thank you. Good evening, everybody, and thank you very much for having us. And thank you very much for kind words. So my talk is on low-grade lymphomas, and I'll try to touch upon few concepts of low-grade lymphomas in 30 minutes. I don't think I'll describe morphology. We can't do that. So I'll just touch about what is indolent lymphomas, which is low-grade lymphomas in peripheral blood, in bone marrow, in lymph nodes, extranodal sites. So we don't have any entity in pathology by benign lymphomas. Lymphomas are generally called as malignant only, but we have indolent proliferations. They can be B cell, T cell, NK, plasma, even myeloid cell we have. Like we have CHIP. I'm sure you heard in the morning today, clonal hematopoiesis of indeterminate potential. Similarly, we have lymphomas which could be low grade. Indolent and low grade is very overlapping. We'll discuss that. And then we have aggressive lymphomas. Again, B, T, NK, plasma, myeloid, monocytic, histocytic, dendritic. Now, just to briefly tell you, indolent, clonal, lymphoid. Now, these are the new entities. When I was even 20 years back, it was not known to us. It was known in the literature, but not well defined. So this is a question in the final exam. It can be a question in the exam for postgraduates. What are the indolent clonal lymphoid proliferations? And they can be nodal, they can be extranodal, they can be in the peripheral blood. Can anybody tell me in the bone marrow, which can be the indolent clonal lymphoid proliferation in the bone marrow? MGUS. You know MGUS? Like we have M band, and then we can look at the plasma cells in the bone marrow. And in peripheral blood, any indolent? MBL, monoclonal B cell lymphocytosis, which is a precursor of CLL. MGUS is a precursor of myelomas. So there could be, again, as I mentioned, TB, myeloid, NK. And these are the types of indolent, like in situ mantle cell, pediatric variant of follicular lymphoma. These are very, very low grade, means these lymphomas, if they occur, you can leave them. You don't have to treat them. Maybe just observe them. But some oncologists do give mild treatment. And as I written in the last, MBL, MGUS, and CHIP. This is the precursor of CLL. This is a precursor of myeloma. This is a precursor of MDS. Low-grade lymphomas. We know that we have lymphomas of B and T type. and some are NK type, some are plasma cell. 80% of lymphomas, 70% of lymphomas are B type. 15% are T type. So most of the lymphomas are B cell type. And we can do clonality to sometime when you have a problem, is it benign or malignant? So we do clonality, though clonality is not a gold standard, it can be tricky. So we can't depend upon clonality all the times. It's basically your history, clinical findings, and morphology with IHC, which is mostly good enough in 95% of cases. 5% cases or less than 5%, you may need clonality. You can do clonality by both molecular methods or by flow. So now, as a pathologist, we have to be careful. As an oncologist, we have to be careful. The most important is we don't have to do any harm to the patients. Because if I give a diagnosis of a lymphoma, my medical oncologist will treat. So you have to be careful how do you word the report. Because there are many instances in my practice, even Dr. Borges is not there, when we have a difference of marginal zone hyperplasia versus marginal zone lymphoma in a single node, we prefer to call it marginal zone hyperplasia. Now, what's the reason for that? The reason is only one. Patient can live because marginal zone hyperplasia and single node marginal zone lymphoma, patient will live life very well. And if it's incidentally detected marginal zone lymphoma or a hyperplasia, many times we have erred towards hyperplasia. I'll give you quickly some examples. We have a 57 female. She came to one of the Hinduja hospital in Bombay for routine checkup, and she had a normal, but her DSC showed 52% lymphocytes. Now, generally we know that lymphocytes are 20 to 40%. But here the lymphocytes are slightly high. And you look at the white cell count, so then you find the absolute count. So absolute count looks okay, not more than 5,000. So it's less than 5,000, but it is still high. So what do? You leave the patient. In India, we don't bother. We leave the patient because so many patients might have borderline higher lymphocytes. And there can be many causes of reactive lymphocytosis, high altitude, smoking, many viral infections. So what you do in our practice, we call the patient again, maybe after a month or 2 months, and repeat. If still patient has more than 40-45% lymphocytes, and if patient can afford, patient is asymptomatic. So you don't have to touch him. Now, if you want to give the scare to the patient, you can do flow cytometry. And we did flow cytometry here. And this is a morphology, normal looking lymphocytes here and there. Smudge cells you can get in normal smears. Smudge cells do not mean CLL. Smudge cells can be seen in normal smears. It can be seen in ALL, can be seen in other lymphomas also. So there is some lymphocytosis, and we did flow. On the flow, it was a clonal B cells, which were CD5 positive. You can see here, these are the lambda, all the red dots, they're all lambda. So the clonal B cells, they're CD5 and CD45 positive, and they were 19 positive. So 5 positive, 19 positive, lambda light chain restriction. I am dealing with CLL or mantle cell lymphoma, most likely. So I do other markers like 23, CD200, CD43, LEF1. They're new markers. Maybe I do cyclin D1, SOX11 too. And based on that, I came to a diagnosis that this patient has a CLL phenotype. These scanty tumor cells, but they have CLL phenotype. But it is not CLL because the absolute count is less than 5,000. So what do? We calculate the absolute count. We know that lymphocytes are 52%, total count is this much. So we call it, there are monoclonal B cells with CLL phenotype. So the new name of this entity is MBL, monoclonal B lymphocytosis. It's a benign disorder. In this room, if we take sample of all of us, one of us might have MBL. Similarly, one of us also might have MGUS. It's mostly seen in 50 years and above. MGUS, MBL, the chances of picking up are more if you are adult, elderly. So this was MBL, can be low count, can be high count. So this was high count, and we need to follow up these patients. That's all. I will skip these slides. Go to, when we were students, we were told CLL is a low indolent disease, but it is not true. Now we know that there are cytogenetic abnormalities. There are some cytogenetic abnormalities which are bad, Like if you look at the bad CLL, these are like you need to do flow. 49D positive, it's a bad CLL. IGVH unmutated is a bad CLL. Fish, TP53 mutation, bad. Deletion 17P, bad. However, deletion 13Q is good. So we all know now that all CLLs are not low grade and patients will live for 30, 40 years. So we need to work up now. 20 years back, 30 years back, when I was studying CLL, okay, low grade. No, it's not a low grade. There many of them can progress fast, and there are so many newer drugs which we didn't know 10 years back. Now, what we do, my colleague Nikhil, he does panel for CLL now, genomics. So, more you study more, you evolve more, you learn more molecular. So you pick up more abnormalities. So we are learning. Case 2. This patient is a case of carcinoma bladder. He came to Tata Hospital in the urology clinic. Carcinoma, urinary bladder. But patient incidentally had high serum globulins. Globulins were high, serum proteins were high, and the globulins were high. So once the surgeon sitting there had some medical acumen also, a smart surgeon, he said, the globulins are high. Let me do the serum electrophoresis. He did the serum electrophoresis. There was an M band, monoclonal M band, but very short, very thin band, less than 1 gram. So it was not myeloma because there were no features of myeloma, and M band also was very thin. But the patient came for carcinoma bladder, and we told the patient that you have M band. So for now, doctors have to be sure they did the bone marrow. Bone marrow was done, and bone marrow showed only 3% plasma cells. Like here, you can see 1 or 2 scattered plasma cells. So patient is normal, only carcinoma bladder. Now we are investigating him for his 3% plasma cells in the bone marrow. We did the flow. Now in the flow, we do some markers like 138, 38. We pick up these scanty plasma cells. How many? So in the bone marrow, we pick up only 1% plasma cells, which express 38, 138. The rest are all neutrophils, erythroid cells, myeloid cells. Only 1% plasma cells. Now I will study these 1% plasma cells, and I look for their behavior. Are they clonal or they are polyclonal? Means are the kappa lambda equally divided or they're not? We saw that their lambda is slightly more than kappa. The ratio is reversed. So the reverse ratio means it's abnormal. Lambda is generally less half. So we narrowed down to small population, which was CD27 negative. This is all the plasma cells. CD27 negative, these are abnormal. And they all were lambda. So we have a very small population of, so we have 3% plasma cells in the bone marrow, which is normal for an adult. And out of 3% cells, maybe 1% cells were clonal. So what do? You don't call it myeloma because it doesn't fit into the myeloma defining features. There's no other features. We know that end organ damage, anemia, thick M band. No, nothing was there, no lytic lesions. So we called it MGUS-like signature on flow. Now, MGUS is a diagnosis based on serum electrophoresis. You need to do serum electrophoresis for M band. But now you can we pick up many MGUS on flow. A patient comes for follicular lymphoma. In addition to follicular lymphoma, it has MGUS. Patient of CLL has CLL and MGUS. So you do more technologies, you do more sensitive, high color, high end flow cytometry, 10 color, 15 color, 20 colors. Now we do 18 colors. If you do 15 to 18 colors, you'll pick up more small population like minimal disease. The question is how sensitive you want to go and you want to scare the patient. So like I told you, MBL is we have told you, MGUS I told you, something similar is CHIP, CHOP. Now CHIP, my previous speaker, she mentioned, is clonal hematopoiesis of indeterminate potential. And if you take people in this room, not in this room, they're all young. If you take a group of 100 people who are more than 60 years of age, healthy adult people more than 60 years of age, maybe 2% or 5% might show you one of these mutations. Now, these mutations, if you detect, then we label those people as CHIP. You have a CHIP. He says, I'm healthy. But we'll say, no, you have a CHIP because you have one of these mutations with low VAF. So CHIP is here. Then there's something called as non-clonal ICAS, then something called as clonal cytopenias, then becomes low-grade MDS, then becomes high-grade MDS. So this is a long, my time is over. So yeah, so I just give you one example, then I stop. I think I won't go to the lymph nodes. So this is a 34-year-old female who came with bicytopenia, suspicion of MDS. So can you do clonality for myeloid cells? Anyone? How do you do? We do clonality for T cells by immunoglobulin gene rearrangements. Clonality for T cells by T cell receptor gene rearrangements. How do you do clonality for myeloid cells? We look for mutations. I've already told you. So mutations means it's a clonal population. This is abnormal. So we did morphology was normal. We can't call it dysbiosis. No. We did flow was normal. Fish, we do common panel for fish. It was normal. We did NGS. In the NGS, there was a frame shift mutation in TET2 gene. You can see here, TET2 gene framed to mutation, and VAF was very less, 4%. So it was a case of bicytopenia. So now we call it clonal cytopenia of undetermined significance, because patient has cytopenia, but significance is not there. So these are the new entities. So I won't go into the details. These are our panels in Tata Hospital for myeloid genomic panels. I think I'll skip this. This is LGL. You can get LGL like pictures post-imatinib, post-rituximab. Now we give a lot of these targeted therapies. So LGLs can increase in number. NK cells can increase in number, and they can be clonal. It's not a leukemia. And this is a good sign, actually. I think I'll stop here. Thank you.
Thank you so much, sir, for your expertise and insights and for leaving a lasting impression.
Thank you.
I request our chairpersons to felicitate Dr. Sumit Gujral, sir. I request Dr. K.T. Dave, sir, Associate Professor, VDGMC Latur, to felicitate our chairpersons for this session. Following this wonderful presentation, we have our next insightful presentation on the topic Approach to Plasma Cell Dyscarrias by Dr. Santosh Khubba, sir. For this session, I would like to invite Dr. Surekha Kadade ma'am, a professor at Ashwini Medical College, Solapur, and Dr. Shivaji Birare, professor and HOD, Department of Pathology, Sindhudurga, to chair this session.
I would like to take a moment to introduce Dr. Santosh Khubba, sir. He is a renowned hemato-oncologist and bone marrow transplant physician. He has fellowship in bone marrow transplant and cellular pathology. He is a postgraduate program in cardiology. He has various paper presentations and publications in his credit. I request sir to continue.
Should I start? Finally, with the 2 days conference of the Hemat-Onco and also Oncopath along with the Hematology conference. Today it's a time for the plasma cell, and that too at the last. Since my UG days, I am observing this plasma cell as the most neglected cell in the hematology. In the UG also, I learned the plasma cell at the end of the pathology. In the PG also, I learned hematology as an optional subject. And at the end of the DM also, I learned the plasma cell at the end of the curriculum. So this is the beauty of the plasma cell, but don't neglect plasma cell. Once a plasma cell starts neglecting you, it will be very horrible for everyone. So for that, there is a need of the learning this plasma cell dyscrasia. The presentation outline is the just historical aspect of the plasma cell disorders. What are the plasma cell disorders? When to evaluate, how to evaluate, and the management of these plasma cell disorders. Actually, why there is a need to learn the plasma cell disorder? Because it is a 1% of the all malignancy, even though it is taught in the last pages of the all the books, but it is very important. And out of the all the hematolymphoid malignancy, it is a 10%. of which is contributed by the plasma cell disorders. The spectrum is very wide. As sir was saying that monoclonal gammopathy of unknown significance, which just requires a monitoring. But at the same time, if you get a plasma cell leukemia, you will not even get time to diagnose also. Till that time, patient passes away. As per as this time, the median age of the plasma cell was quoted by the US and UK studies, and even in the 2024 update on the diagnosis, risk stratification, and management of the myeloma is a 65 years. But don't forget, there was a paper published by the Kaustubh distribution of the myeloma in India, which showed the most of the people from the northern and central zone of India having the chances of getting myeloma is very high, and that too at the early age, that is a 50 to 59 years. Usually, it was very difficult to remember in our UG days ki the age distribution of the diseases, the which disease occurs at which age. But usually we remember myeloma occurs at the old age because it is written in the last pages of the book. But it is not like in India. It comes earlier than the Western population. So be careful whenever you get some myeloma symptoms, which we'll discuss ahead. If it is coming in the early age, that even around the 50 years of the age, you should not neglect this plasma cell disorder. So historical aspect, in 2008, Nikhil Munshi has published very beautiful paper that is a one disease which is contributed by the bone lesion, plasma cell infiltration in the marrow, and clonal immunoglobulins in the blood. That is a some group of the disorder, but they could not find out what was the reason of all this group, this problem. So now from that area, they diagnosed the plasma cell disorders, including the lymphoplasmacytic lymphoma. And now we are at the stage where we can define the minimal residual disease of the myeloma through the matrix, through the MALDI-TOF and the mass spectrometry. So this is a just history where we can see the first documented case was in the 1844. To get a one case series, it took a 80 years of the duration for the multiple myeloma. And after that, in the last 10 years, it was evolved with a huge number of the pharma companies are involved for the scientific research. So at the same time, the treatment had started in the 1840, evolution of the treatment with the quinine, but it has not at all given any benefit for the myeloma. But in the 1940, they tried the urethane. In fact, the patient who has been treated with urethane, those having the overall survival is very less than the patient who has not treated. So after that 10 years, no one touched to the myeloma. But in the 1950, again came the melphalan as a game-changing drug for the myeloma. So after that, there was a too much of improvement in the myeloma care. In the 2015, we got a newer molecules like a daratumab, elotuzumab, ixazomib, and the panovinostat. These are also all the therapies like anogenic transplant, CAR T cell therapy, bispecific, trispecific, and immunotoxins. Everyone will not afford this until and unless there is an insurance. So who is at risk? These are the male patients, age with more than 50 years, Gaucher disease patients, first degree relatives of the myeloma, African Americans, obesity all time, radiation exposed, petroleum industries. So with that, what are the plasma cell disorders we should know? The most common are being the 6 disorders: monoclonal gammopathy of unknown significance, moldering myeloma, solitary plasmacytoma, Poem syndrome, systemic amyloidosis, and plasma cell leukemia. Other disorders which are uncommon, including the lymphoplasmacytic leukemia. So when to evaluate? Once a plasma cell start neglecting you, you will get an anemia, for which you will go to the local doctors. He will transfuse and he will still neglect the plasma cell. Then there comes a easy bruising, bleeding disorders. Then the third thing is a bone pain. Usually people go with a bone pain to the orthopedician. Then he notices that something is going wrong. He will operate and again he gets one more fracture. Then he realizes there is a something related to the plasma cell. Then there is the fatigability. The one bad part of this plasma cell neglect is a recurrent infection, which can be the life-threatening. So how to evaluate CBC, peripheral smear, retic count, biochemistry, including creatinine, blood urea nitrogen, serum beta 2 microglobulin, then the specific investigations for the particular plasma cell disorder. These are the SPP, immunofixation, SFLC, and also the skeletal survey, bone marrow study, and FISH, CK, and NGS. The multiple myeloma diagnostic criteria has been provided in the 2014 with the International Myeloma Working Group. These are the clonal marrow plasma cells of more than 10%, or the biopsy proven bony or the extramedullary plasmacytoma. And along with any of the one myeloma defining event, both of them should be fulfilled. Then what are the myeloma defining events? One is a end organ damage defining criteria like hypercalcemia, which is more than 11 milligram. Not only 11 milligram, if you are getting 1 milligram high than the baseline calcium, still you can consider it as a hypercalcemia. Even in the same case with the renal insufficiency, where the creatinine is more than 2 or the creatinine clearance is less than 40, which is undiagnosed renal failure, still you can consider it as a plasma cell disorder. Anemia of HB less than 10 gram or the drop of hemoglobin of more than 2 gram percent than baseline can consider it as a maybe because of the plasma cell disorders. Then the bone lesions, more than one osteolytic bone lesions can be considered as a myeloma defining events. There are the three more criteria which has been given by the newer classification. These are the clonal marrow plasma cells if are present more than 60% or equal to 60% in the marrow. If they are giving the involved versus uninvolved serum free light chain ratio is more than 100, provided that involved light chain should be more than 100 milligram per deciliter per liter. So there should be the one more criteria, that is a more than one focal lesion on the MRI study of at least 5 mm in size can be considered as a myeloma defining event. Why these three criteria are important? Even though there is a no end organ damage, if these criteria is fulfilled by the patient, there is a need to treat all these plasma cell disorders, because these all things can lead to the life threatening disorder in coming 1 year. Then how much a percentage of the people will get if the life threatening events is more than 90%? So it is very important to know these all things. So then, after seeing all these criteria of the myeloma defining event and the diagnostic of the myelomas, SPP has never written in any of the diagnostic criteria. Then why we do the SPP? Just to see the clonality and to define asymptomatic cases like the monoclonal gammopathy of unknown significance. There are the two types, light chain monoclonal gammopathy and heavy chain monoclonal gammopathy. Heavy chain again involves two things, non-IgM and IgM type of the monoclonal gammopathy of unknown significance. So the third thing what I want to elaborate is the solitary plasmacytoma. It is very notorious disorder. It only forms the only one area is involved, only one bone is involved, without involving the marrow, without secreting any light chains, and even without any end organ damage, along with a normal plasma cells in the marrow. Then there is one more entity which has been defined, that is a solitary plasmacytoma with minimal marrow involvement, which shows only less than 10% but clonal plasma cells. There is one more entity. If at all it is a solitary plasmacytoma, if the marrow is showing more than 10% clonal plasma cells, then you have to define it as again myeloma, and you have to treat like a myeloma only. So the management part. So management will involve the emergency care considering the anemia, hypercalcemia, renal failure, bone fractures, hyperviscosity, supportive care in terms of vaccination, antiviral, anti-PCP prophylaxis, antibiotic prophylaxis for initial few months, and then the bone strengthening treatment and IVIG support. So with this background, there are the anti-myeloma drugs. There are different categories of the drugs. And nowadays, so much of drugs are in the pipeline for the FDA approval. The first one is an alkylating agent, like a cyclophosphamide and melphalan. Protease inhibitors, these are the bortezomib and carfilzomib. Then the immunomodulators like lenalidomide, thalidomide, and the pomalidomide. Monoclonal antibodies against the CD38, these are the daratumab and also elotuzumab. The fifth category is these are the all new drugs. When we don't get any response with these old drugs, we go ahead with the newer drugs like the histone deacetylase inhibitors and the nuclear exporters, that is selenoxafor. Few novel drugs which are in the pipeline but not affordable yet to the everyone apart from the insured person. These are like venetoclax, which is a BCL2 inhibitor, which causes the apoptosis of the plasma cell. There are the few bispecific like BCMA, anti-G. These are all BCMA, G protein coupled receptor, carbohydrate fraction of the receptor, heavy chain, fifth domain. These are all receptors present over the plasma cells. This center cell is named as the plasma cell, and these are all the receptors. These bispecific are the antibodies. One limb of the heavy chain is already attached to the CD34, and another one will go and attach to the plasma cell, where it causes a cascade of the inflammation, and the plasma cells will killed by the own immune system. So the similar mechanism is a CAR T, which uses a target on the plasma cells like the BCMA, this G protein coupled receptor, CD19, CD38, and SLAM7 as a antigen. So with this background, risk assessment of the disease, it includes, I only want to elaborate 3 staging systems: international staging system, revised international staging system, and M-SMART risk stratification. In the initially international staging system, they included only 2 parameters, that is the serum beta-2 microglobulin levels and the albumin. With this, they classified into the 3 categories. But to make more precision in the in informing to the patient how much he will survive and what will be the behavior of the disease, they included 2 more entities in the revised international staging system, that is a FISH for the myeloma cells and the serum LDH level. The further again M-SMART classification came into the practice that included the high plasma cell S synthetic phase and the high risk genomic expression profiling. So with that, why LDH is considered the specifically because it causes increased proliferation of the plasma cells, more aggressiveness of the disease will be defined, and the presence of the tumor mass, that is extraosseous or extramedullary. This is about the risk management, the risk assessment of the disease. But before treating the patient, we have to assess the patient, what type of treatment we can give. Even there are the few patient related factors like old age, poor performance, comorbidities, last but not least, that is the finances of the patient. So the clinical features, whether it is MGUS, whether it is a smoldering myeloma, whether it is a plasma cell leukemia, or whether it is involving the some extramedullary part of the body. The disease is a specific biological features which we have defined with a FISH and gene expression profiling. The high risk expression profiling is a new one. Though here is the central dogma of the treatment of the myeloma. How we treat the myeloma? Basically we have the 2-drug regimen, we have the 3-drug regimen, and now the 4-drug regimen is into the routine practices, and the FDA approved all these therapies are there. As I have shown earlier, there are the different categories of the drugs. So out of those, we have to choose which drug we can combine and add to the patient's treatment. It depends on all these risk assessing factors, which I have shown previously. So now, is the patient candidate for the first thing is whether there is a need of the treatment to the myeloma, plasma cell disorder, and if at all there is a need of the treatment, then what type of treatment we should give. Is the patient is a candidate for an autologous stem cell transplant? Yes, then go ahead with a 3 to 6 cycles of the triplet or the quadruplet therapy as an induction chemotherapy. Then we have to go ahead for the consolidation chemotherapy, whether to give the stem cell transplant therapy, or whether to continue as an induction therapy as a consolidation regimen and go ahead. And at the last, when the disease is in the complete remission, then we can go ahead for the maintenance therapy to maintain the response to the disease. No doubt, once you complete the maintenance therapy, you just can continue the supportive care for the same. This is the basic funda which has been given by the International Working Myeloma Group. If the patient is the first time diagnosed as a myeloma, but he is a transplant eligible, then if it is a standard risk, then you can go ahead with a daratumab, bortezomib, lenalidomide, and the dexamethasone combination. Here we can see the DARA and isatuximab is given as an option of the best treatment modality. But at the same time, here again the finances comes. With that finances, we have to give something which can patient afford. That is a VRD regimen, depending upon the further any comorbidity to the patient. So the early HSCT in the standard risk is ideal, but if patient cannot afford, then we can go ahead with the just cryopreserved stem cells to avoid the toxicity to the marrow with a further subsequent chemotherapy. No doubt, if it is a high risk, then we have to go ahead with the induction and the early autologous stem cell transplant with a maintenance of the true drug regimen, that is a Borte and lenalidomide. If it is a transplant ineligible patient, we have multiple and very affording drugs for the treatment. Yes, after this, so many drugs, so many combination of the treatment, is it curable? Not at all. The myeloma or the plasma cell disorder is only treatable disease where you can give the multiple combination of the drugs multiple times and with a proper guidance of the hematologist or the expert. It just keeps a only treatable condition and only remission is our goal. Myeloma is not curable. Then what is the issue with that curability? The issue is with the genetic alteration. As we give the chemotherapy, there must be some new addition of the mutations that will cause a resistance to the drugs. The epigenetic alteration, same mechanism will follow for the drug resistance, abnormal drug transport, escape from the apoptosis, and then the cancer stem cells, tumor microenvironment, immunotherapy, antigen escape. All these are the mechanisms which can cause a which leads to this disease as a only treatable condition, not a curable condition. So these are all the relapse modalities. Whatever we have not used in the first line management, these all are can be used in the first relapse or the subsequent relapses, and all what are I have shown the all new agents. These all can be used as a subsequent relapse treatment modalities. So here, take-home message for this approach to the plasma cell disk crisis is that don't neglect to the plasma cell. Second thing, the disease spectrum of the plasma cell varies, plasma cell disorders varies from the asymptomatic monoclonal gammopathy of unknown significance to the aggressive behavior of the plasma cell leukemia. The disease is not curable. It is only treatable disease. With the available treatment of options, the patient quality of life improved significantly, but even the improvement of the quality of life is required. So the newer treatment, newer agents are in the research pipeline for the treatment of the myeloma. So I am very thankful for inviting me here and giving the opportunity for this talk of the session. Thank you.
Thank you so much, sir, for enlightening us with this interesting and informative topic. I request our chairperson to felicitate Dr. Santosh Khuba, sir. I request Dr. S.N. Kantikar, sir, Assistant Professor, VDGMC Latur, to felicitate our chairpersons.
Now, proceeding towards the valedictory function, it's my pleasure to welcome you all to the valedictory function of the Oncopathology Workshop and Hematology Conference. Over the past 2 days, we have had the privilege of engaging with some of the brightest minds in the field of pathology. Our oncopathology workshop has featured total 30 selected cases for live slide discussion, along with the 16 enlightening sessions on hematology by the eminent speakers, and also the exploratory panel discussion on the pancytopenia. Truly, we are overwhelmed with the knowledge we have gained through all these illustrative sessions. As it is said that the more we learn, the more we realize how little we know. The more we know, the more we realize how much we still have to learn. We extend our sincere gratitude to all the speakers, panelists, and participants for making this conference a great success. I request Organizing President Dr. Umesh Kannade sir and Organizing Secretary Dr. Sangamesh Chavanda sir to kindly be on the stage to felicitate our winners for the paper and poster presentation and also to felicitate our sponsors. Now it's time to announce the winners of paper and poster presentation. First of all, the winner in oral paper presentation is Dr. Shweta Deshmukh. Dr. Shweta Deshmukh, Mahadevappa Rampure Medical College, Kalburgi. Dr. Shweta, please encourage our winners with a huge round of applause.
I request judges to please highlight what criteria you have followed for the posters and the papers.
Winner for the paper presentation, Dr. Shweta Deshmukh. Now second winner for the poster presentation, clinical poster, Dr. Shubham Bankar from VDGMC Latur. Dr. Shubham Bankar, someone please have the prize on behalf of Dr. Shubham. And now be ready. Winner of the pathology poster, Dr. Bhagyashri Tekale from Grand GMC and JJ Group of Hospitals, Mumbai. Dr. Bhagyashri Tekale. Thank you so much. So it was all about the winners of our paper and poster presentation. Now it's time to felicitate our sponsors who are indeed our partners in progress. I request representatives of the sponsors to kindly come on stage and accept the mementos. First of all, Om Sai Pathology Lab, Latur. Om Sai Pathology Lab. Next, be ready, Mandade Hospital. Our next sponsor, Mandade Hospital, Latur. Then third one, Dr. Ravi Chavanda Memorial Hospital, Latur. Next, be ready, Krishna Surgical Pathology. Krishna Surgical Pathology Lab, Latur. Representative of Mandade Hospital, Latur. Kindly please accept. Now, Krishna Surgical Pathology Lab. Next, Shubham Pathology Lab. Shubham Pathology Lab. Dr. Acharya, sir. Mandade Hospital. Then Gandhi Hospital and Gandhi Cancer Care. Kindly come forward to accept our token of love from the organizers. Next, Nihon Corden. Nihon Corden. Please, next sponsors, be ready. Horiba, Nihon Koden, Horiba, Arba Transasia. Please be ready. Sysmex. Truly, these are the sponsors which are helping in our day-to-day pathology practice through their various innovative machineries, cell counters, Arba Transasia, Sysmex. The next, be ready, Sun Pharma, representatives from the Sun Pharma. Aditi Distributors, Aditi Enterprises. Then Renwick. Now, Neon Curtain will be accepting the mementos. Next are the Ideal Healthcare, representatives of Ideal Healthcare. Then Aristo Pharmaceutical Private Limited. Then Windray. Windray Healthcare Within Reach. Next, Beckman Coulter. Next, representatives are of Beckman Coulter Life Sciences. Next, Ideal Healthcare, Sarvesh Distributors. Next are the Sarvesh Distributors. Next, be ready, Visionsoft Computers. Visiosoft Computers. Next, kindly come on the stage, Biogenics. Representatives of Biogenics. AV Core. Now, Biogenics. Next, be ready, Home Distributors. Please have a big round of applause for all our partners in progress. ICICI Bank. ICICI Bank. Then Natco Pharma Limited. Natco Pharma. So we have total 24 sponsors for today's function. Anyone remaining? Any of the sponsors? If they are remaining, kindly come up on the stage. And most important, to host our CME, PVR, Team PVR. Team PVR. Now I request Dr. Kanade sir to have few words.
Just I want to say thank you very much. But this single word doesn't mean it's all over. It's again the beginning, because our team, the organizing team, has exhausted day and night to make this conference and the workshop successful. I thank you very much all the organizing team, the committee members, the Department of Pathology, VDGMC Latur, Latur Association of Pathologists and Microbiologists, all the co-hosts, those who are participated, helped so much. The venue PVR, it has make a very good landmark and well appreciated by each one of you. So thank you very much. The delegates, those who have traveled all over the Maharashtra and also from the nearby states, thank you very much for all the delegates, all the participants and all the head of departments from all the institutes, those who are shared the slides for the discussion in this oncopathology workshop. Thank you very much. And I would like to thanks Dr. Sorry, all those are doctors sitting here. So Rakesh will be the doctor again. So Rakesh sir, please welcome on this your stage and on in PVR Cinema. Thank you very much for providing the PVR as a host. We have got a very good Audi, very good staff support, the security support, and the parking area. Thank you very much. Yes, one more thing I want to highlight that before completing this conference, we were thinking of to do some public awareness program. So we have done one public awareness program on the anemia and cancer awareness. Only it was thought of for 2 days, and the huge response was there for this rally. So we have done the anemia and cancer awareness program also. So everybody who has participated, directly, indirectly, those who are supported, all the sponsors, those who are supported, I am thankful for everyone. Thank you very much.
Thank you, sir. Now, Rakesh sir from PVR team, kindly have a big round of applause for Team PVR and Rakesh sir. Also, I request all of you to please put your hands together for the organizing committee of this hematology conference and oncopathology workshop, who have worked diligently to bring us all together today. And also,
Come on
thanks
stage,
to their
all committee
tireless efforts in making this event a big
Everybody should be on the
success.
stage. Please come on first, because we have to go for the banquet also. Please come fast, everyone. Come on, Vishal, Nagapure, everybody on the stage, please. Darvesh sir. Yeah, Jayshree madam, yeah. All the volunteers, come on the stage. Undergraduate students. Sorry, तुमचं नाव विसरलं माझं. नाही मी विसर्शन करायचं.